Are you ready? Oh, all right. Good morning. Oh, sorry. Good morning. My name is Dr. Brandy Gotti, and today I'll be presenting a case review focusing on early onset symptoms of hearing and balance loss in individuals with Creutzfeldt-Jakob disease. What is Creutzfeldt-Jakob disease? It is a rare and invariable fatal neurodegenerative disorder that is classified under the spectrum of transmissible spongiform encephalopathies. It was first described in the 1920s by Hans Gerhard Creutzfeldt and Alphonse Marie Jacob. The term prion was coined by Stanley B. Preussen in 1982 and is derived from the term pernicious infectious particles. And the prion hypothesis proposes that misfolded prion protease-resistant proteins propagate, inducing a misfolding in the normal cellular protein, which then causes accumulation of protein in the brain and subsequently neurodegeneration. While typically presenting with symptoms such as cognitive decline as well as behavioral changes, an atypical presentation of Creutzfeldt-Jakob disease includes sensorineural hearing loss as well as balance loss. And our case review highlights the importance of identifying these uncommon presentations to understand the pathophysiology of Creutzfeldt-Jakob disease, to guide our clinical decision-making, as well as improving patient outcome. Now, let's discuss the different subtypes of Creutzfeldt-Jakob disease. We have sporadic, genetic, and iatrogenic. Throughout the three, we have sporadic as being the most common, accounting for 85 to 90% of all cases, and it usually affects individuals that are middle-aged or elderly, and the median onset is around 65, and median survival rate is actually 4 months. Now, how does the clinical presentation of CJD present? It is typically detected late in progression, which demonstrates with rapidly progressive dementia, as well as monoclonus, pyramidal and extrapyramidal signs, visual and cerebral disturbances, as well as akinetic mutism followed by death. Now, the diagnostic criteria for CJD is for a definitive diagnosis can only be made through positive brain testing, usually conducted during autopsy through their histology, immune histochemistry, or a Western blot. However, you can provide a probable diagnosis to individuals if they demonstrate a neuropsychiatric disorder with a positive real-time quantitating induced conversion in the cerebral spinal fluid, or dementia with at least 2 of the following features seen on the slide, and then they actually have to have a positive lab test of either an EEG demonstrating periodic sharp waves or a positive 1433 cerebral spinal fluid, high signal in either the putamen or the caudate, or at least 2 cortical regions in a DWI or a FLAIR, and if it has a genetic form, then they can demonstrate it in genetic sequencing. Now, we had several aims in our case review. Our primary aim was to characterize otolaryngologic presentations of CJD and to focus on hearing and balance disturbances. Our second aim was to evaluate the timely relationship between the otolaryngologic signs to the classical neurologic signs, because we proposed that hearing loss and actually balance disturbances were preceding the classical neurologic symptoms of CJD, which provides a critical window for early detection and diagnosis. Now, through our methods, we did a systemic review done following PRISM, as demonstrated in this figure, and we used PubMed database to utilize the analysis of all case reviews from 1990 to 2024, using keywords Creutzfeldt-Jakob disease, as well as hearing loss and balance. And a total of 16 cases were retrieved, 11 were used in our study, and cases were analyzed and identified key associations, symptoms, as well as commonly utilized testing in making the diagnosis. And through our results, as you see through our figures, we saw that a total of 8 patients demonstrated hearing loss and 3 had balance loss. Out of the individuals with hearing loss, half were male and half were female. The average age that demonstrated hearing loss was 63.75. And then out of the 3 patients that demonstrated balance loss, 2 were males, 1 were female, and the average age for onset of balance was actually 46.67. And the most common CJD symptoms seen in patients that presented with balance and hearing loss was gait impairment, followed by myoclonus, as well as impairment, as well as akinetic mutism and visual disturbances. And our review found that the most common used diagnosing tests were MRI, EEG, real-time quaking-induced conversion, as well as 1433 cerebrospinal fluid testing. Now, understanding these common symptoms seen in CJD is critical for early detection. While current treatment remains palliative, early detection helps give an opportunity for better patient outcome, as well as preparing these families of the patient. While hearing and balance loss are actually atypical presentations of the disease, clinicians will fail to identify these patients without understanding all symptoms that commonly accompany CJD. And the most common seen symptom, as we discussed in hearing loss, was the gait impairment. Due to the rarity of these symptoms, when otolaryngologists see patients that have balance and hearing loss accompanied with these symptoms, they should have high suspicion of CJD and understand the necessary imaging and the specialists that these patients should be seen. And since hearing and balance loss are not well-established symptoms of CJD, they might be overlooked as a differential diagnosis, which can lead to underreporting as well, and this can impact in a twofold. It hinders the timely diagnosis and management of CJD. Also, it limits the availability of published case reports, as well as large-scale studies linking the hearing and balance loss. The variability in the diagnosing modalities can also be used to access hearing and balance loss, might introduce challenges in identifying the symptoms and reducing potential use of early detection. And giving this definitive diagnosis can typically require neuroimaging as well as hearing and balance testing. And a standardized approach to CJD diagnosis would help minimize the symptoms, minimize these limitations and help establish a link between these atypical symptoms of CJD. And further research is needed to understand the neurodegenerative mechanisms affecting the hearing and vestibular function and its diagnosis and potential in therapeutic interventions in improving patient outcome. Thank you for listening to my presentation.
There's another lecture on there that I was going to do. You guys have the other one on there? All right. I figure we'll learn about something else a little bit. So this green button to move? All right, perfect. Okay. All right, so for those who don't know me, my name is Michael Toscano, one of the fifth years at McLaren, Oakland. I talked to Mackenzie about why are we lecturing at 6 in the morning again, she said I could lecture on anything. So we're going to talk about how to make sauce and meatballs. So what you'll need, so what I like to use is 4 cans of DOP San Marzano tomatoes. The DOP is important because that's how you know that the tomatoes were regulated in where they were grown and how they were cared for. I use a 1/4 cup of olive oil, some butter, onions. I grate it, you'll see in a couple pictures here. Minced anchovies, which gives some complexity to the flavors of the sauce. Carrot, garlic cloves, basil, tomato, etc. You see it all up there. For the meatballs, I found the best ratio is 2:1 ground beef to ground pork, 2 eggs per pound of meat that you're using, about 2.5 pieces of bread per pound. Milk, you got to soak the bread in the milk. You'll see that coming forward. Some fresh parsley, grated parm, breadcrumbs, salt and pepper. Tools, how do you do it? Well, you need a chef's knife. You always want to have a chef's knife on hand. Immersion blender is helpful. Cheese grater, mixing bowl, saucepan, Dutch oven. So this is everything here. I don't know if, oh, here we go. Okay. Yeah. So this is what I was talking about for the canned tomato, the DOP down here. You know, it's assimilated to like, okay, hey, if you got a good champagne, you get a certified good champagne, you know where it was grown, you know how it was cared for. That's sort of the same thing with tomatoes here versus like a sparkling wine. So you got your mixing bowl, your pan, Dutch oven. I like the 4C, for the meatballs, I like the 4C Italian breadcrumbs. For the cheese for the meatballs, it doesn't really matter. It's going to be cooked, so you don't really need the fanciest Parmesan cheese for the meatballs. Eggs. A little tomato vine is helpful to add some flavor to the sauce when you're making it. And down here is a picture of sort of soaking, or actually not yet, but you will be covering this bread up to the top with milk to help soak it and keep it very moist. And of course, you got fresh basil here for later on, as well as fresh parsley. All right, so you know you open up, and this is for if you're making sauce in the winter. You use cans because they're canned fresh. It's going to be your freshest tomatoes versus the summer, which you could do fresh. It's just, there's a few more steps in between, but that's sort of outside the scope of this talk. So you get the tomatoes in. I like to just use an immersion blender initially. You could just use your hands and leave a good amount of chunk in there. And then you take out 3 cups, put it in the fridge. And whatever you have left, that's what you're going to use to make your sauce initially. You'll add the 3 cups of fresh tomato sauce, again, to give that complexity of flavor later on. So what's going to be your base, right? So here we have like a teaspoon of both oregano and basil. I've found when I've used a tablespoon of oregano or a little more, it overpowers the dish, it overpowers the sauce. You taste more oregano than really anything else. You don't even taste the anchovies, which we have here. This is 8 garlic cloves chopped up. This is the onion that's grated on a cheese grater. I think it helped enhance the flavors. And then some finely chopped carrots there. So what we do, right? So to start, you get, So to start, we get, 4 tablespoons of butter, as well as with, 1/4 cup of olive oil in there. Then once that's all, dissolved or warmed up, add in the onions, the oregano, a little dry basil, and a couple, my kids don't eat the sauce if it's too spicy, so I can't put too much red pepper flakes in there. So, and then once that's all cooked and the onions are translucent, you add in the carrots, start getting those cooked. And then eventually you add the tomatoes, right? You add the tomatoes to it. I add the fresh tomato vine for flavoring, as well as just big sprigs of basil. Get it in there. Once it starts to bubble, you put it in the oven at like 280 to 300 degrees, at least for my oven. You have to find the right spot for your oven, because if it's bubbling too much or if it browns too much, if the brown bits are burning, then you're going to want to decrease the temperature, okay? So once you get that in the oven, it's time to do the meatballs, right? So what we'll do is in this bowl, you have everything sort of together. We talked about the 2-to-1 mixture of beef to pork, fresh chopped parsley, that milk-soaked bread, the breadcrumbs, and then the eggs and everything. You mix them all together. And we got all the meatballs here. And what I like to do is I like to have them to the right, and I work my way to the left, as you'll see here. So I'll get the first batch in, great. Once they're done, we start moving them over, and we start getting other ones in from the right, moving to the left onto these paper towel-covered plates. Once that's all done, you let it sit. They get added. Mind you, the sauce is going to cook for probably 6 hours around. So when there's about 2 hours left in the sauce, I'll add the meatballs, which is what you see here, and get it back in the oven. This is just parsley and basil. That's going to be roughly chopped for the end here. After about an hour left, actually, in the cooking process, I'll add the fresh tomato juice or tomato sauce that we took out in the beginning and put in the fridge, remember? So you want to add that with about an hour left. Let it cook for that extra hour. When it's done, you take out that tomato vine, which you see here, and take that out. And what I like to do, because those carrots are in there, right, they're likely cooked down anyway, but I'll get the immersion blender in there again and just really incorporate them into the sauce. And then at the end, I'll add the fresh parsley and basil with some, olive oil. And there you go. That's how you make it. And the kids love it. So thanks for coming to my TED Talk. We could do ramen. That was on New Year's. Ramen. Any questions?
Yeah, next time, boil your meatballs. Do it. Boil your meatballs.
Oh, wait, what?
Yeah. You boil them? Yeah, you boil them, so I'm Italian.
Yeah, you look, I'm looking.
You boil your meatball, it keeps the moisture inside the meatball. So you gotta make sure it's dense, and then you boil them for about 20 minutes, and then you put them in the sauce. So, and then it gives the flavor.
All right, good morning. Let's get back to some otolaryngology, right? That was great to learn about the sauce. So, my name is Trevor Diepenbrock. I'm a second-year osteopathic medical student at A.T. Still University in Kirksville, Missouri. And today I have the honor of discussing some of the recent research in the field of otolaryngologic ultrasound. So we'll cover some potential new uses, how artificial intelligence, or more specifically machine learning, is being integrated into the imaging process, and a few frontiers in producing effective training models. Whether you're certified in ultrasound or prefer that imaging out, this research can be beneficial to your future practice. So for some context, we'll review some of the well-established uses for ultrasound that may be leveraged by the otolaryngologist. Sonographic examination is a key early step in the workup of thyroid nodules, along with gathering TSH. Ultrasound plays a further role in guiding the fine needle aspiration of such lesions to evaluate for carcinoma. A similar approach is used for salivary glands, and in many scenarios, we may leverage ultrasound to help locate cervical lymph nodes. A new use of ultrasound, which has been getting increased attention in the past few years, is in the acute examination of potential nasal bone fracture. Though, of course, this is far from appearing in any clinical guidelines, its moderate specificity and sensitivity rivals that of plain film radiography, so it might serve as an alternative imaging modality in patients for whom radiation is contraindicated. So keep an eye out for improvements in this realm, because that may creep its way into some guidelines. So especially during the COVID pandemic, the potential for flexible laryngoscopes to aerosolize microbes led some otolaryngologists to seek alternatives. Although the pandemic may be over, researchers, including San Calipore and colleagues in their 2023 review, have continued to examine various transcutaneous laryngeal ultrasound uses. Findings show potential in assessing for vocal fold function, particularly surrounding thyroid surgeries, as well as an examination of the pediatric airway. There are still debates over the best practices of these scans, such as whether the focus should be on the arytenoids, the vocal folds, or the false vocal folds. Other examined uses of cervical ultrasound include the supplemental imaging of laryngeal neoplasms as an adjunct for video fluoroscopy and dysphagia, and in helping guide cricothyroidotomies and laryngeal electromyography. So AI is definitely everywhere these days, and definitely the one that gets the most attention is the generative AI images that are created. So it's therefore likely no surprise that AI, in other forms, is a key research focus throughout medical imaging, and it comes with a lot of opportunity for the otolaryngologist. The general workflow of many studies here is training machine learning algorithms or neural networks on a large validated data set before testing it on a smaller sample. The AI can thus use ultrasound images to make predictions, even in patterns the human eye can't quite recognize. In the ultrasonographic evaluation of head and neck neoplasms, research has primarily been on risk stratification and diagnosing different tumor types. AI has shown potential in predicting extrathyroidal extensions, For example, of carcinomas and lymph node metastasis. Oh man, it looks like the word stratification jumped right onto that part, but it says extrathyroidal extension of the carcinomas, as well as lymph node metastasis of papillary thyroid carcinoma. It also has been used to just do pure risk stratification of thyroid lesions in general. It's been tested in different tumors using sonographic features alone, but also including thyroid carcinomas and salivary gland tumors. Another fascinating use is providing real-time feedback for finding resection margins in tongue carcinomas, which Bakedem and colleagues developed by mixing pathology slides and 3D ultrasound. During fine needle aspiration, it's been used, as well as in segmenting thyroid nodules. Other key predictions AI may soon provide is who might experience dysphagia post-stroke, helping to diagnose obstructive sleep apnea without polysomnography, and this last one is pretty cool, predicting velum collapse in drug-induced sleep endoscopy, even when the ultrasound can't quite reach all the way to the velum. So with commercial products like this one here, the Blue Phantom soft tissue thyroid biopsy ultrasound training model costing nearly $2,000, a lot of institutions are seeking cheaper alternatives. So the common methodology that many studies employ is using patient CT images to make a 3D model, which they then convert into 3D printed molds. These are then filled with various augers to correspond to the echogenicity of the tissue that they're trying to replicate, and then they put them all together into a single model. So the example here is made with PVC mixed with various powders and follows such a protocol. So we can see the estimated cost of this model is about $140. So in ENT, the focus has been on developing thyroid models and full neck models, featuring both normal and pathological anatomy. Thyroid models are designed to highlight features of different types of nodules, and they range from anatomically accurate models following that 3D printed protocol I mentioned, and that's the one on the top left follows that. But they also can be as simple as a chicken breast stuffed with grapes, pimento olives, and raspberries to represent different types of nodules. That's more of a fun one, but both of these models cost around $5. Just the difference is the cost of a 3D printer is a lot more than the cost of a chicken breast. But for full neck models, like the one on the previous slide and this one on the right, there are definitely a lot more time that needs to be put into creating these. But as Hassan and colleagues demonstrated last year, an ultrasonographically accurate neck model can be produced for around $60 a piece. These DIY models can help trainees better understand their anatomy, help them feel more comfortable in approaching pathological scans, and help facilitate learning ultrasound-guided procedures more quickly. So though this is a small sample of studies, I hope you all can appreciate the work that researchers all around the world are performing to improve the use of ultrasound in otolaryngology. They're examining new scans, they're using AI to streamline the diagnostic process and make predictions, and they're working to lower the cost of ultrasound training so physicians can feel more comfortable in approaching normal anatomy and pathology. With these ongoing improvements, particularly that there are already multiple FDA-approved AI programs which can be integrated into ultrasound machines for otolaryngologic purposes, we can expect ultrasound to be a stronger tool in the otolaryngologist tool belt going forwards. And thank you, and I am now open to questions. I also have copies of my citations because there are a lot of them. Thank you.
All right, good morning. This is not the secret sauce, but this is a simple, quick reminder of the connection between hearing loss and the silent path to cognitive decline. So I think it's an important topic to review, but I'll just get started here. Essentially, we know dementia is this progressive cognitive decline, whether it's Alzheimer's, Parkinson's dementia. In general, dementia is under this umbrella of just a progressive cognitive decline. Hearing loss, it's commonly underdiagnosed in aging adults. There is an emerging link between hearing loss and dementia, so we're going to kind of discuss that a little bit more. Untreated hearing loss, we know doubles the dementia risk. Mechanisms behind this include social isolation, cognitive load, brain atrophy, which has been shown in studies. The Academy guidelines actually say, hearing screening is recommended for adults greater than 50 years old. So it's just something to kind of be more aware of when you're seeing new patients in the clinic, that they may not be as aware of their hearing loss because it is a gradual thing that people often accommodate to, but something to be aware of and to make sure that we're picking up on in screening. So only 20% of adults with hearing loss use hearing aids, and untreated hearing loss accounts for 30 to 40% faster cognitive decline. So what is the role of hearing aids? It improves your auditory input and brain stimulation. It keeps those neural pathways, patent essentially, and it promotes social engagement and a potential to delay and prevent cognitive decline. So there are a couple studies. Amiva et al. In 2015 demonstrated cognitive decline that was slowed with hearing aids. And Deal et al. In 2023 also demonstrated hearing intervention benefit, as well as MRIs that showed hearing aids were linked to brain volume maintenance. So restored communication pathways, you reduce depression and loneliness, and you have improved neural activity. These are some of the mechanisms of protection. So challenges and barriers. There's a stigma with hearing aids. A lot of times people come into the clinic and they say, I don't really feel ready for hearing aids. I don't like the look of it. I don't want to seem like, I'm old or something like that. And often what we'll say to patients as well, you wouldn't necessarily leave the house without your glasses if you have vision issues. And so hearing aids have come a long ways, and there's, hearing aids that are in the ear, behind the ear, very easily kind of hidden. And there's a lot of benefits that we need to make sure that we are advocating for, fall prevention, prevention from isolation and loneliness, picking up on certain things in the surroundings that improves our safety in the elderly population in those neural cognitive pathways. So we need to work on, cost and accessibility issues, need for better public health messaging, and just advocating for this in general. So what are the clinical implications? Routine audiologic screening in ENT and primary care, early referral to audiologists, and integrating hearing rehab into dementia prevention. So in conclusion, hearing loss, it's a modifiable dementia risk factor. Hearing aids may slow cognitive decline, and we need public health, clinical education efforts in order to promote this and advocate for this, and I think just having a high index of suspicion and being advocates for our patients. So here are my references, and that's my son. He's 9 weeks old. His name's Morgan.
Hey everybody, I'm Joel. I'm the first year ENT resident at Kettering Health Dayton. Earlier this year, we had a case that came in that was tongue necrosis. Couldn't really figure out why, so wrote up a case study for it, and this is it. So a little background. Giant cell arteritis. It's a medium to large vessel vasculitis. More often affects women of Northern European descent and those older than 50. Symptoms include typically constitutional symptoms, often a unilateral temporal headache or tender to palpation there. Vision disturbances or vision loss, some jaw claudication, and rarely tongue necrosis. It's often associated with polymyalgia rheumatica, which is just like kind of a stiffness, soreness, typically in the neck and neck, shoulders, and proximal thigh region. Tongue necrosis often presents with tongue pain, ulcers, edema, and pallor. The diagnosis itself, you have to be over 50. You can have a temporal headache, tenderness to temporal artery, and an ESR of at least 50. Gold standard being temporal artery biopsy showing arteritis. So for Our Lady, we had a 79-year-old who presented to the emergency department with progressive tongue pain and swelling that's been around for about 2 to 3 days. She did have a history of breast cancer. She had DVTs. She had a recent fall where she said she bit her tongue, and she was taking lisinopril for hypertension. Some of her associated symptoms with it was she was having some jaw pain with some difficulty opening her mouth, which was thought to be likely due to pain. On initial exam, there's just diffuse edema through the tongue, kind of a faint hue to her tongue, some mottling that was tender to touch. And there was a small area of ulceration kind of on that left side of her tongue there. There was concern for angioedema because of her lisinopril use. Thought it could be trauma to her tongue since she said she bit it whenever she fell. And then there was also the possibility that she potentially threw a clot from her DVTs. In the emergency room, they were worried about her airway, so they intubated her. Diagnostic tests were ran. Her white blood cell count was normal. Her CRP was elevated, but not quite to where you would meet the American College of Rheumatology's criteria for it. They want it to be over 10 before you can get any points for GCA. ESR was 39, so it was again elevated, but not quite to that 50 level. Temporal artery ultrasound didn't show any of the classic halo sign that you would typically think to see. CTA of the neck should be pretty much normal for the most part. No vessel occluding disease. You just couldn't see the left lingual artery, and they said it was potentially occluded. So right now we're not doing so hot with our diagnostic criteria based on the American College of Rheumatology. So far we just have tongue pain, which gives us 2 points, and they wanted at least 6 before they can really make a diagnosis of it. So we went for, she was extubated 8 days after her edema and stuff had improved. She had been taking steroids. She followed up with us in clinic 10 days later with now near complete bilateral tongue necrosis anteriorly. She returned to the hospital for tongue debridement and temporal artery biopsy with high-dose steroids. During the biopsy, her tongue just auto-amputated whenever we went to go pick it up and just slid right out of her mouth. So this was her at clinic And then this is her remnant tongue after the biopsy. So she was placed on high-dose corticosteroids, and the temporal artery biopsy, along with the tongue biopsy, showed giant cell. So, despite confirming her diagnosis, treating her with steroids, she continued to have ischemic complications. She was left with a huge oral cavity defect, having less than a third of her tongue left. So she continued to have dysphagia. She underwent a PEG tube placement and was discharged home after that. So she followed up with rheumatology for giant cell management. We consulted head and neck for possible reconstruction of her tongue, but due to shared decision making, both the head and neck team and her decided not to go through with it. So now she's left with her remnant tongue and PEG tube dependent. So just some things to consider when an elderly patient presents with tongue pain, modeling bilateral necrosis. It's important to consider giant cell. We did have one patient that came in probably a couple months after her that did have some bilateral anterior necrosis of her tongue, and since we had this case, it had been high on our radar after that. Turns out she was just biting her tongue. So this case, it was kind of tough to decide on whether or not what it was. She had her previous trauma where she fell. She said she bit her tongue. She had her history of thrombosis. Could have potentially threw a clot, though it would have been weird to have thrown it bilaterally to occlude both sides of her tongue. And since she was on lisinopril, there was the potential for angioedema, but that was way lower on our risk. And also, she only had met the two diagnostic criteria for giant cell, being the tongue pain and the positive temporal artery biopsy. But that put her at a score of 7, so it made it over the 6 that the rheumatology college had wanted. So I think it's important to maintain a high level of suspicion when elderly adults present with unexplained tongue pain and discoloration. A quick diagnosis can help limit irreversible tissue damage and auto amputation. So early intervention will help decrease morbidity associated with the tongue necrosis. And that's all I got. Yeah.
After 10 days when she was discharged, was there a working diagnosis at that time, or what was the thoughts, after 10 days?
Yeah, so after the 10 days, we were thinking that it was the giant cell. We decided to go for that biopsy. She had actually left and then came back to the emergency room, and then that next day we went and did the temporal artery biopsy.
But that was on your thought prior to her being discharged, that she might have that?
Yeah, the first time we had seen her, we were like, what the heck could it be? So we were just looking around and stuff and found a few case studies that said giant cell could potentially cause bilateral tongue necrosis. So we're just like, oh, okay, well, let's give that a whirl. So we went for that biopsy, and that's what confirmed it.
So had you found out at day 2 or something, what management would have changed that? Do you think you could have prevented that tongue necrosis? Or?
See, that's the hard part, because we did give her steroids while she was in the hospital initially. I guess you could have gone like with non-steroidal treatments for giant cell, like I think some other like monoclonal antibodies and stuff like that. But steroids was really all we could think of at that time. And it's just unfortunate that that it just kept continuing to lead to that necrosis. Anything else? Appreciate y'all.
All right. Good morning, everyone. My name's Sunny Kadam. I'm a PGY2 from McLaren, Oakland, and I'll be talking about sympathetic chain paraganglioma. Perfect. So it starts off with a 59-year-old gentleman who presented for incidental finding of a left parapharyngeal mass undergoing CT for a workup for ACDF. He initially presented with neck pain that went on for about 6 to 8 months. He got some relief with gabapentin, but nothing really, took care of that. He noted some gravelly voice changes as well as dysphagia, and his social history was significant for 8-pack year history as well as being a current marijuana user. So on exam, everything was relatively normal. A scope did show a left submucosal lateral wall swelling of the oropharynx, but his true vocal folds were seen to be mobile and symmetric in motion. All right, so here's a copy of the CT scan. See if they'll see. So we want to take a look at that left parapharyngeal space that shows a 3.6 centimeter hypervascular mass arising from the left carotid space, as well, and splaying the internal and external carotid arteries. And it was also noted there were some non-specific left level 2A and 2B lymph nodes as well. And then an MRI was done, which showed a heterogeneous T2 signal intensity mass arising from the left parapharyngeal space that was approximately similar dimensions, 3.4 centimeters. And they noted, the etiology of the mass was actually uncertain and recommended, several differentials, including the nerve sheath tumor, schwannoma, paraganglioma, or even a salivary gland tumor. So at this time, our suspected diagnosis was a carotid body tumor. And, the treatment was surgical excision paired with preoperative embolization to help reduce bleeding risk. So kind of just briefly touch on the surgical procedure. Cranial nerves 10, 11, 12 were all preserved. The tumor was found to be extending to the skull base, so therefore mandibular subluxation was performed anteriorly to allow for distal exposure of the internal carotid artery. And dissection was carried in an inferior to superior fashion. The parapharyngeal space mass was found to be deep to the common carotid, internal as well as external carotid and IJV. It was seen to be splaying just as similar to the imaging of the ICA and ECA. And instead of originating from the carotid body, it was seen to be arising from the sympathetic cervical chain. So decision after this was excised was to proceed with C5, C6 ACDF. During the post-op visit, patient was doing fairly well. Status was excision of that left sympathetic chain paraganglioma and ACDF. He did have a visit to the ER within the interim, where he went for hypertension. Systolic was over 200. Fortunately, they got it under control, and he was discharged home that day. But patient was positive for first bite syndrome, which I'll briefly talk about in the next couple of slides. He did have a left Horner syndrome with ptosis and meiosis due to excision of the sympathetic cervical chain, as well as an additional CT abdomen pelvis was ordered to rule out any other, paraganglioma-like growths such as pheochromocytoma. So before we talk about, sympathetic chain paragangliomas, just briefly review some anatomy about the parapharyngeal space. It is an inverted pyramid shaped space. So the apex is down below at the hyoid bone, with the base is at the skull base and the tympanic tube above. The medial boundary is the pharyngobasilar fascia and superior constrictor, and it's bounded laterally by your pterygoid muscles and mandibular ramus. Anteriorly, it's bounded by the pterygomandibular raphe, and posteriorly by the prevertebral structures. And then it's also further divided into your pre- and post-styloid components. The main structures in your pre-styloid component consist of your maxillary artery as well as your ascending pharyngeal artery, and this also encompasses the deep lobe of the parotid. And while the post-styloid compartment houses your internal carotid, your internal jugular vein, and then a couple cranial nerves, 9, 10, 11, and 12, as well as the cervical sympathetic chain. So there's a big variety of tumors of the parapharyngeal space, but most often you'll find paragangliomas, pleomorphic adenomas, squamous cell carcinoma, among others. And usually these are only palpable as neck masses once they exceed that 2.5 to 3 centimeter growth. Therefore, making early detection of these tumors pretty difficult other than on incidental CT finding. All right, so sympathetic chain paragangliomas are well-vascularized carotid-shaped lesions. Usually imaging will show lateralization of the ICA, but often you can also have splaying of the carotids. It's a pretty rare etiology, about 20 to 30 cases reported in literature, and patients will often present with Horner syndrome, oropharyngeal fullness, and there's a little bit of a higher rate of catecholamine secretion. So this is a retrospective chart review from 2012 from Vanderbilt about tumors of the cervical sympathetic chain. They examined 24 cases from 94 to 2010. And then most commonly, patients presented with dysphagia, a neck mass, as well as throat fullness, as well as a Horner syndrome. Classically on imaging, 42% of patients had lateral displacement of the internal carotid, but about 38 demonstrated splaying of the carotid, similar to carotid body tumors. And then common postoperative complications were, 33% had first bite syndrome, 57% had Horner syndrome, and then 14% had cranial nerve weakness, which were two patients had vagal weakness and one had spinal accessory weakness. So it's important to note that both sympathetic chain tumors and vagal tumors can mimic carotid body tumors. And then briefly, just wanted to talk about first bite syndrome. So it's characterized by increased pain and increased salivation, usually with the first bite of the day, but this will gradually subside with subsequent bites. The theory behind this is damage to that sympathetic plexus leads to overactivation of the parasympathetics, and patients with this are at increased risk to develop this with the transparotid and transcervical approach. Fortunately for the syndrome itself is self-limiting but may be permanent. So management, starts out pretty conservative, starting with dietary modifications and avoiding certain gustatory stimuli. But other neuromodulators can be used for neuropathic pain, such as gabapentin and carbamazepine have been noted to be successful. And then more invasive treatment options are, intraparotid Botox, approximately 40 units, as well as auriculotemporal nerve resection and stellate ganglion nerve block. All right, and that's my references.
Good morning. Thank you for being here. This is 7 a.m. on a Saturday morning at this conference. It's probably the hardest time slot, I think. It normally looks like this or less, and I'm happy that you're all here. One problem that we have with some of our lectures in the past when we get subspecialists involved is that what is in this for me as a general ear, nose, and throat doctor? Or I do mostly thyroids and head and neck. Why is this information pertinent to me? Today, I think you're going to find that we have 2 hours of plastics content that is extremely applicable to a general ear, nose, and throat doctor or a general ear, nose, and throat doctor's knowledge base. And this is not very esoteric. This is stuff that we all learned the foundation of in our residency and that we probably should know as general otolaryngologists and can certainly do as general otolaryngologists. My very first speaker this morning is Anya Costello. I had the pleasure of Anya being a resident in one of the residency programs that I taught at. At the time, it was Ascension Warren, and now it's Henry Ford Warren. She then went off to San Francisco to UCSF to do facial plastics, and then has found herself at Bella Cosmetic Surgery in National Harbor, Maryland, where she's been doing facial plastics now since her fellowship. She's going to be talking about lower eyelid rejuvenation, and without further ado, I'll let her have the stage.
Hi, good morning, everyone. Thank you for being here so bright and early on a Saturday morning. And thank you for the introduction. So my name is Anya Costello. I'm in private practice in National Harbor, the Washington, D.C. area. And how do I go to the next slide? Is there a clicker? Is this it? Oh, cool. I don't have any disclosures. And learning objectives for today is to briefly talk about how the lower eyelids age, what are the goals of someone looking for lower eyelid rejuvenation, my own personal algorithm for lower eyelid rejuvenation, and choosing the correct technique based on the anatomy, which then minimizes complications with lower eyelid rejuvenation. So common concerns that I see with patients is people come in with bulging bags, puffiness under their eyes, loose skin, wrinkles, dark circles. And the goals of rejuvenation is to smooth that lower lid and cheek junction, to remove any herniated fat and reduce the puffiness or the bags that people complain about, to reduce a deep tear trough, and to do this while maintaining eyelid support and position. So anatomy of aging. With aging, we have bony resorption. The orbit gets bigger. Their fat changes. The fat pads will separate. They'll herniate or descend. And there's also ligament laxity that happens, which can be the orbitomalar ligament or canthal support. And then the midface will descend, and there will be a separation between the lower lid and the midface. And on top of all that, there's skin changes. There's wrinkling of the skin becomes less elastic and more crepey. So clinical evaluation, I look at 5 different things when I see my lower eyelid patients. So first I identify the problem. Is it orbital fat? Is there too much of it? Is there not enough of it? Prolapse, hollow. Is there a deep tear trough creating like a bump, hole, bump appearance? And then looking at the surrounding structures. So the lateral canthus, the shape of it, is it short, is it rounded? And looking at the canthal tilt. And then looking at lower lid laxity, the snap test, the distraction test. And then vector analysis, which looking is the eyeball prominent or is it sunken in? If it's prominent, the patient could have some underlying medical issues, thyroid problems, so keeping that in the back of the head. And then looking at skin, is the skin quality and is there excess skin? So part one is identify the problem. Are they hollow? Do they have the bulging orbital fat? Or is there a deep tear trough? And some examples. This is a young patient, and she does not have any bulging fat, but she does have some under eye hollowing, creating a shadow under her eyes and then a deep tear trough. And then this patient has kind of the opposite problem. She does have some bulging fat, but very minimal tear trough. And then this patient, both of these patients both have bulging orbital fat and that deep tear trough. And then part two, looking at the patient's anatomy, is their anatomy make them prone to malposition after a lower eyelid surgery? Do I need to support the lower lid when I do the lower eyelid surgery? So to assess this, I look at the globe to cheek relationship, so that's that vector, is the eye prominent? I look at the lateral canthal, laxity and position, and do those tests to check the lower eyelid tone. And then the last question is, do I need to treat the lower lid skin? So lower lid canthal laxity distraction test, you pull the lower lid away, and if you can pull it further than 8 millimeters away from the globe, then that's abnormal and that's a sign of laxity. And snapback test, you pull the lower lid down and watch it snap back. If it takes longer than 5 seconds to snap back, that's also a sign of laxity. And if either of these tests are abnormal, that's a indication that the lower lid does need to be supported because there's a big risk of retraction or ectropion. And then canthal position and canthal tilt. So is there canthal rounding the lateral canthus? Go back. So this is an example of negative tilt. So looking at a line from the medial canthus to the lateral canthus, on that axis, is it tilted negatively or positively? And then looking at vector. So the most anterior projection point of the globe to the most anterior projection point on the lower eyelid and the malar eminence. And when the globe is posterior to the anterior aspect of the malar eminence, the vector is positive, and that's lower risk for retraction. In this patient, he actually had a negative vector, so his cheek is posterior to the most anterior portion of the globe. And that's another sign that you need to do something to support the lower lid during the surgery. And then finally the skin. So there's quality and then there's quantity. The patient above, it looks like she had poor skin quality, but she didn't really have excess skin. Like when I pinched her skin, I usually pinch the skin, have the patient open their mouth and see if I can still pinch anything, and there wasn't really anything left when she opened her mouth. The patient below her, he actually had a lot of excess skin. So with him, I did more of a skin excision. With her, it was more of a skin tightening. And then looking at the tools that we have to treat all of these problems and picking the right ones. So non-surgical tools, there's fillers, there's laser like CO2 and erbium, chemical peels, and then there's surgical options. So lower blepharoplasty, doing things with fat, like transposing the herniated fat or doing fat transfer to the lower lid to add fat. And then treating the skin with skin pinch, skin flap, skin muscle flap. And to support the lower lid, you can go from just doing a frost stitch for a week to doing a canthopexy to a full canthoplasty. So briefly, I'll just go over how I do the lower blepharoplasty. I do most of mine transconjunctival. I make an incision 6 millimeters below the inferior tarsal border, and I use a silk, 5/0 silk to retract. I release the septum, usually with some Q-tips, and then when I put some gentle globe pressure, the fat will present itself. And one of the first steps for me is to identify the inferior oblique muscle, because then I can know where I am and I can stay safe, not hurt the muscle, and get the fat pads out. And then identifying the medial, middle, and lateral fat pads and assessing the herniated portions. And then hemostasis is very, very important during this. You know, if you get bleeding and it retracts back into the orbit, that could be devastating later if someone has a hematoma, because that would be an emergency. So I'm very, very careful with hemostasis. And then I excise the herniated fat pads. How much to excise? I look at the inferior oblique and I look at the orbital rim and I make them level with the inferior oblique and the orbital rim. And then in some patients, if they have enough fat, I transpose the fat. And this is the video. Can you hit play? So it's really important to have no tension when you free the medial and middle fat pad attachments to the inferior oblique. And this was, I don't think that's playing. Are you able to hit play? It's not playing. If you click on it. Well, that's okay. So what that video was showing is the Dr. Mastery's, he talks about in his videos, it's the shoe shine sign. So you have the medial and the middle fat pad underneath the inferior oblique, and you can pull them back and forth freely, and they move without any attachment. So that's all that that's showing. So once there's no tension, I release the fat. I have it kind of looks like a little omentum in that first picture. And then I identify the inferior infraorbital bundle. It's about 1 centimeter inferior to the orbital rim. And try very hard not to get into it. If you get into it, there's a lot of bleeding. It's a really tight area. It can be difficult to control, but it's not the end of the world. You just have to get hemostasis. And then once I identify that and have the fat, I pass the suture through the cheek. I grasp the fat, and then I pass it back under through a little telfa. I think I picture that. Yep. So I secure it in place with a 3/0 nylon and a telfa, and cover it with a steri strip and leave it in for a week. And then in other patients who don't have enough fat to transpose, or even in patients who I transpose the fat, I typically do fat grafting to blend the transposed fat. And I use microfat for volume and to create structure. And I'm showing that on her right side of her face. And then nanofat for skin texture and skin quality in the tear trough. And that's the red on her face. And just briefly, for fat grafting, I tumesce the abdomen, the thighs, wherever I can get fat. Harvest about 100 to 140. I recently started centrifuging because I felt like my fat wasn't concentrated enough before that. And I use telfa to get the oil out, and then I use the 2-loop connectors to create microfat and then nanofat. And then I inject it with 18 to 22 gauge cannulas. The survival rate that I've seen with patients is about 50 to 80%. It's hard to predict. So I do have that discussion with them preoperatively and tell them, I don't want to overfill because I can't. It's a lot harder to take it out than to add more. But if all of it doesn't survive, we may need to do another session down the road. And then for lower lid tightening, ranging from the least to most that you can do, tarsorrhaphy. I do that in a lot of patients if they have any of those factors that would make them at risk for malposition. And I just do a little frost stitch from the gray line to the gray line. The lateral aspect of the upper lid, I leave it in for 5 to 7 days, or as long as the patient will tolerate it. Patients don't love it, but usually they are able to tolerate it for at least 5 days. And then canthopexy, so I usually do, if I'm just doing lower lid, I just do the little transcanthal canthopexy technique where I make a small little incision in that lateral, like one of the crow's feet, just lateral to the canthus, and then I suspend with a 5/0 PDS. And then it's, for cosmetic patients, I rarely do canthoplasty. If someone already has pre-existing retraction or pre-existing ectropion, then I do that. But just for straight blepharoplasty patients, it's pretty much never do it. And then lower lid skin, so skin laxity. Typically, I treat it with deep laser resurfacing. We have a Cyton laser, so it's erbium YAG. If they have excess skin, that's when I either do a skin pinch, skin flap, or a skin muscle flap, depending on how much excess skin they have in their anatomy. And for the skin pinch, the green forceps are really nice because you can just pinch the skin and then excise it. And just some cases. So this is that patient from earlier who's young, doesn't have any herniated fat pads. She does have a deep tear trough, great skin quality. So with her, I just used filler. I did about 0.3 cc's of Restylane per eye. For the tear trough, I did probably like less than 0.1 per eye, and then I blended the lid-cheek junction. Another patient, so her problem was herniated fat, minimal tear trough, but pretty significant herniated fat. Her vector's neutral, positive canthal tilt. She didn't have any laxity. She's younger, has great skin quality. So for her, it was just a lower blepharoplasty. I actually did an upper on her as well. And she was very happy. So this is the patient that had both the bulge and the deep tear trough. So a neutral vector, she had slightly positive canthal tilt, no laxity. You know, she's young, she's in her 40s. But she did have some skin laxity, but no excess skin, and she did have a little bit of early mid-face ptosis. So for her, I did the transcondylar lower blepharoplasty. I transposed her fat because she had so much of it, and I also grafted the fat to blend that junction. And then I did under eye deep laser resurfacing. And then this is another patient, fat bulge, anterior trough. She had neutral vector, positive tilt, good skin quality. So in her, I did transcondylar lower bleph and some fat grafting, and she was very happy. He was a more challenging patient. So he has the fat bulge, the deep tear trough. He had canthal laxity, so like distraction test and snapback test. He had a lot of laxity. And he also had excess skin, neutral vector. So for him, I did the transcondylar lower bleph. I transposed his fat. I grafted more fat to blend it. I did a canthopexy. I did a skin flap for him. And I did a tarsorrhaphy, left it in for a week. And then this is a patient, she had a festoon. So she had a left festoon. I don't know if it's a little bit hard to see in that picture, but it was pretty prominent. And she also had bulging orbital fat, mild tear trough, some skin laxity. I did the transcondylar lower bleph. I did fat grafting. Sometimes with festoons, I would do like a skin flap. With her, she didn't have a lot of excess skin, so I just did the deep laser resurfacing and did some extra passes over the festoon. She had a lot of red. She's still pretty red there under her eyes because she's, I think, only like 2 months out here. But it did treat the festoon really well. And this was another more challenging one because she had a lot of bulging orbital fat. She had a deep tear trough. Her vector is neutral, borderline negative, neutral tilt. She did have some lower lid rounding on both eyes. If you look at her lateral lower lid, there's some rounding there. So, and she had a lot of mid-face ptosis, so I was worried about malposition with her. And I did the transcondylar lower bleph, fat transposition and grafting, canthopexy, and a tarsorrhaphy. And complications, I'll go through that. With fillers, you can get lumpiness, you can get edema. This is a patient who came in she had under eye fillers done somewhere else, and it was like years ago, and all of a sudden she developed this lumpiness. Luckily, we have Hylenex, which dissolves HA filler, so I dissolved it, and it resolved, and she's happy. After laser, one of the most common things that patients complain about is milia and prolonged erythema. That's one of my patients who, like a month out from laser, has a lot of redness, has milia. So for milia, I deroof them. I tell them just to kind of wait and reassure them. I don't have a great treatment for milia. It's annoying, but they go away. And for redness, I've tried giving patients topical steroid cream. It has kind of mixed results, so mostly just time and reassurance. With surgery, chemosis, this is my patient, he had chemosis. He actually had a rare underlying eye disease that he didn't tell me about until after the surgery, so he had a lot of redness, a lot of issues, and then he told me about this disease, and I was like, oh, that makes sense. For chemosis, the suspected etiologies are like we disrupt the lymphatic system, the inflammatory, pre-existing dry eye. I think sometimes injecting the way that local is injected can cause it. Management, I do steri strips. I try to put the lower lid like up and over the bleb and push it down, which helps. And Maxitrol drops, Medrol dose pack. And for retraction, preventing it by treating, by supporting the lower lid, recognizing it early, because if you recognize it early, you can do like the 5-fluorouracil injections and an upward massage. And that, with patients who've had early retraction, that has solved it and haven't had any issues. Also, steri strips to tape the upper eyelid up. And then ectropion, prevention is really important for that, supporting lower lid. And then if you have it, then canthoplasty, like a lower lid shortening, tarsal strip. And this is just a little summary of different problems, treatment options. Some things I didn't talk about is like under eye hyperpigmentation that can be treated with BBL. I usually actually refer patients to dermatology because the Pico and the nano lasers work really well for that. I don't have one of those, so. And then dynamic wrinkles, just using some Botox to treat that. The orbicularis oculi hypertrophy also can be treated with some Botox, just right, the Jelly Roll Botox right under eye. And we discussed the other ones, and those are my references. And does anyone have any questions?
All right, thank you very much. Our next speaker is a New Orleans native, Claire Melanson. She grew up here. She went to LSU for medical school, and then her ENT residency in Wake Forest, and then did fellowship in facial plastics in Houston, Texas. She has a private practice, Audubon Facial Plastics, right down Magazine Street, although Magazine Street's quite a long street. And I'm very thankful to have her speaking for us this morning. So, go.
Good morning, everybody. Thanks for being here today. I'm so honored to speak. Thank you for having me. I have no disclosures, unfortunately. These are the objectives for today: a brief review of septal perforations, going through my algorithm for repair, and then a couple of techniques. I don't really need to introduce myself. That was a great introduction. Thank you so much. But I practice here in New Orleans, and I'm a double board certified facial plastic surgeon here. This is my practice down the street. It is a 100% cosmetic facial plastic surgery practice. I do have a kind of unique niche in revision rhinoplasty and septal perforation repair. So why septal perforations? Most people avoid these surgeries at all costs. So why do I have this focus? I think one of the main reasons is I did receive quite a bit of training in septal perforation repair with Dr. Cardell, who's my fellowship director in Houston. He has a very robust practice there, seeing patients from all over the world. So spent a lot of time learning techniques that work really well from him. I do have a passion for revision rhinoplasty, and that tends to go with the territory. Sometimes there's a lot of septal perforations. And the techniques that I've learned have been very successful, so I feel they're not as frustrating as they can be. And then lastly, I posted this TikTok video a few months out of practice, and it got like 250,000 views on TikTok and a bunch of engagement and people saving it, and I started getting inquiries from all over the US for septal perforation repair, of all things. So my fellowship director used to tell me, be careful what you're good at, because you may end up doing it all the time. I also would say, be careful what you post about, because you also may end up doing it all of the time. So a brief review of septal perforations. They have many different causes, primarily iatrogenic, so after surgery, septoplasties, rhinoplasties, cocaine use, nasal trauma, cautery, autoimmune diseases, and several others. I'd say in my practice, it's the vast majority are iatrogenic or due to cocaine use. I'd say it's pretty evenly split there, with occasional autoimmune disease, but those two are the big heavy hitters there. Primarily, patients present with nasal obstruction, painful crusting, nosebleeds, whistling, and gross nasal discharge. More recently, I think it's the advent of social media. It's people, oh, I shined a flashlight in my nose and I saw a hole. So I'm not sure what inspires people to do that, but that's a pretty common story there. So there's multiple ways to repair perforations. If you look in the literature, you'll see probably tens of 20 different ways to repair them. You can use rotational flaps, turbinate flaps, fascia, bilateral mucoperichondrial flaps with alloderm, pericranial flaps. You can go from minimally sort of invasive all the way to pericranial flaps. So which are the best ones? Arguably, I think the best technique is the one that is most successful in your hands. And for me, I've found the two best techniques in different situations to be utilizing TP fascia and then also kind of the bigger bilateral mucoperichondral flaps with alloderm interposition grafts. So where I trained in Houston under Dr. Kreidel is 100% bilateral mucoperichondral flaps with the alloderm interposition grafts via open rhinoplasty approach. He had exceedingly successful success rates, and but he did this 100% of the time for all of his perforations, regardless of anything else. So early in practice, I had one notable failure using this technique. It was a really challenging patient who had scleroderma with Crest syndrome. I left that case just feeling awful. It was miserable. It was like a 6.5 or 7 hour case. The patient had horrible mucosal quality. The more I dissected the perforation, the larger it got, and tearing everywhere. The rhinoplasty was really challenging. I opened the nose because of her soft tissue contracture. The cartilages essentially just popped out, and I could no longer put the soft tissue over the nose. So I had to do a reduction rhinoplasty. The perforation barely got closed, left very uncomfortable with the repair, and she did reperforate at 3 months, though that was smaller. And so this kind of led me to kind of consider if this approach was good in all situations or if there were some other options that would be better in that situation. So that's where I started experimenting with a well-known technique, which is temporal parietal fascia over PDS plate. And it kind of changed my philosophy on having a universal approach to septal perforations. So I kind of created this algorithm in my practice, and we'll go through a lot more of it as we go through this talk. It starts with evaluating perforations based on their size. So smaller ones, I think, don't necessarily maybe need the most aggressive techniques, and then all the way up to really large. I do not treat perforations larger than about 2.5 centimeters in my practice. That's where I send people to people like Sam Most and who do big pericranial flaps, or just tell them that they may be non-operative. And then secondary to perforation size, I start looking at mucosal quality. Since I've implemented this algorithm in my practice, I've had a 100% success rate. I do these a couple times a month, and I really have felt that this has been a great algorithm for me. So the first technique that we'll go through is kind of the heavy hitter, bilateral mucoperichondrial flaps with alloderm interposition graft via open rhinoplasty approach. This was first developed by Creutzfeldt way back when, I think in the 80s. And it's great for perforations up to about 2.5 centimeters in size, but really no larger than that. It's been described to have about a greater than 90% success rate overall. And the central tenets of this technique are you're going to go via open rhinoplasty approach, so you're opening the nose, gaining wide access to the septum, so you can kind of visualize the entire septum there, and you're separating the nose into 3 layers. Your mucosa, the central cartilage, and then your other mucosal flap. From there, you're going to elevate 4 mucoperichondrial flaps, both superiorly and inferiorly, and then create a tri-layer closure. So you'll repair each mucosal flap, and then in the center, you'll create a 3rd layer there with using alloderm. So for your inferior flap elevation, you'll carry, after you've elevated the mucosa on either side of that perforation, you'll carry that all the way down to the floor and elevate all of the mucosa off of the floor of the nose, extending laterally underneath the inferior turbinate. How far laterally you go is really dependent on how much mucosa you need to recruit. It's helpful when you make your lateral incision out there to make a back cut so you get a nice rotational flap to be able to use in that reconstruction there. You will have exposed bone laterally during healing, which heals wonderfully. It takes about a month or so to remucosalize. For hemostasis, I usually put in some Surgicel there. And it's kind of a pearl when you're elevating over the septum there. If you notice there's residual septal deviation, go ahead and address it at that time, because that will also allow you to have more mucosa available to cover your perforation. So next you'll elevate the superior mucoperichondrial flap. So this one we're really recruiting mucosa from beneath the upper lateral cartilages. So this is kind of like a little hidden area that you're able to gain several millimeters of extra mucosa from the superior area. Essentially you'll divide the upper lateral cartilages from the septum and then carefully dissect the mucosa off of the medial border there. Your goal is not to disrupt the mucosa, but to very gently kind of elevate that. I use a caudal to do that. And then you're going to want to extend that elevation, not just at the upper lateral cartilages, but back behind under the nasal bone, so you recruit really as much mucosa as you can from that little area where that mucosa folds on itself. And usually you're able to get, like I said, about 5 or 6 millimeters of extra mucosa, which can be make or break in a big perforation repair. Something to keep in mind is you may end up needing spreader grafts in these repairs once you separate the upper lateral cartilages from the septum. When you're kind of recreating your repair, sometimes you'll need to have spreader grafts. So whether or not you have available cartilage in the nose becomes an issue. So plan for plan B if you don't have available cartilage. I use a lot of donor rib cartilage. I'm a subject of my training, but that's worked really well in these type of situations. So after you've recruited all of this mucosa, 2 flaps superiorly and 2 flaps inferiorly, you're going to do those repair, each of those mucosal walls individually. I always recommend starting on the easiest side first. If you have a really solid repair on one side, it takes away a lot of the stress because your chances of success are already a lot higher. I like to repair perforations, the mucosal, from the edges. So if you have a less risk of tearing through the mucosa. And then the real goal in this situation is to have a completely tension-free closure. That's the whole tenet of this procedure, is that the mucosa, and the advantages to it is that you really have a completely tension-free closure. So for that 3rd layer in the center, I use acellular human dermal matrix. I use alloderm. There's other companies that sell it as well, for sure, that are great, but that's just one option. And then there are many sizes and thicknesses that you can buy. I think the extra thin is really all you need. Alloderm serves as a scaffold for the mucosas to kind of heal over, so you don't need a really thick graft. And then you either can buy it in 2 by 4 centimeters or 3 by 7 centimeters, and you would decide that based on the size of your perforation and whether or not you would need it in any other aspect of your case. You prepare it by putting it in antibiotic saline. You trim it to size once it's rehydrated. I think I typically use gentamicin. You'll lay it over the area of perforation between the mucosal flaps and secured to the caudal septum. I usually secure it with PDS. And then once you've laid it in place, then you end up kind of mattressing the septal flaps to keep it in place. So this is an illustration that kind of shows where you're putting that alloderm. You'll attach it to the cartilaginous septum there and kind of secure it to where it lays nice and flat. Sometimes it's easier said than done. It is easier to use than temporoparietal fascia or temporal fascia, but it can be a little tricky to get it to lie nice and flat. So once it's in place, you have your 3 layers, and you'll end up mattressing those together to hold it in place and support your repair. So mattressing serves a couple purposes. Not only are you kind of securing the alloderm behind the perforation, but you're also bolstering those initial mucosal repairs and kind of keeping the septum where you want it to be, so there's no tension or pull away from that repair. These are just some examples of perforations that I've closed using this technique. And one of the things that I think is really important for all septal perforation repairs is utilizing silastic sheets after surgery. You can buy these individually, but you can also just trim Doyle splints, take the curved aspect of that off. I leave them in place for about 6 to 8 weeks after surgery and secure that to the caudal septum there. This has kind of gotten longer and longer as I've been out in practice. I think it just does so much to preserve moisture in the nose, protect the nose from any insult in that crucial initial healing phase. And I don't think patients really do tolerate it pretty well, usually after about the first week. The first week can be a little challenging as they get used to that, but they tolerate it really well. And I think it really does it makes a huge difference in terms of preserving your repair. So these are just the kind of what it looks like long term. Obviously, this is a pretty invasive approach, but you can see the mucosa heals wonderfully and looks pretty healthy afterwards. So the limitations in this approach, I think, in my opinion, are really in patients who have really poor mucosal quality. I think the risk of enlarging the perforation, ripping the flaps, is too high for me to want to do that in a lot of patients. Sometimes I think it's unavoidable, but if you can avoid that with using a different approach, I think it's worth considering. I think it is a very invasive approach for very small perforations. You're essentially opening the entire nose and elevating all of the mucosa within the nose. So for really small perforations, I think there's other options that can be better and less invasive. And then, once you do a repair like this, future repair, should they reperforate, is pretty difficult. You've got scarring through the nose, you've already opened the nose, all of those things. So that's what sort of led me to consider also using temporoparietal fascia over PDS plate or polydiaxanone plate. So this has been described in the literature many, many times. I by no means created this technique, but it is a wonderful technique, I think, in these situations. It's described to be about 80 to 90% successful overall. And it is simple, it's minimally invasive, and it causes a lot less mucosal dissection and risk. So my technique for these, personally, I do it all endoscopically via hemitransfixion incision, kind of right, I use the left side there, only on one side. I don't do a full transfixion. Then I'll proceed to separate the mucosal flaps around the perforation. And the biggest challenge with these is, and with any perforation repair, is really carefully entering that perforation. You do not want to enlarge it. Always when you're doing a repair, you slightly enlarge that perforation during the repair process, but you want to minimize that as much as possible. You're going to want to leave a cuff around that perforation. You're not elevating the entire septum as you were in the prior technique, but you do want to leave a nice cuff there, at least 5 or 6 millimeters of past the perforation where those mucosal flaps are separated to prepare for your graft. And then after you've done all of that, you're going to remeasure your perforation for actual size. And that'll determine the size of the defect. And so after that, you take your PDS plate. It's like a 0.15 millimeter perforated plate. And and you'll trim it to just past the size of the actual perforation. So that'll determine sort of how you plan for to harvest your temporoparietal fascia graft or deep temporal graft. I would design that to be about over 2 times the size of whatever disc you form. I make it into a nice little circular disc there, which you can kind of see. And you're going to want to get enough fascia to be able to wrap entirely around that disc. I sew it into place with a little 6-0 PDS, so it's kind of like a little sandwich there. And then you can kind of see there's a perforation, it's elevated, you're designing your, I don't think this has a pointer, but your PDS plate based on size to the perforation there, and then cover it with the fascia. And then you can kind of see that that's generally exactly what the process of healing looks like as it remucosolizes. I think it's a really great technique for some of these patients. Patients who have small perforations, I think it's a great approach. Scarred, flimsy, thin, painful mucosa, I think it's something to consider in a smaller perforation or even a medium-sized perforation. And these are typically patients that are going to be post-surgery, where they have a lot of scarring, patients with autoimmune diseases like that scleroderma patient. Anyone who, if you can kind of go in and evaluate that mucosa in that way, I think it's really helpful. So this leads us back to this algorithm. So first, you're looking at perforation size. So the very small ones, I could just go ahead and do that TP fascia. For medium size, that's where I think there's a little bit of a gray area, and I'm looking really closely at the mucosal quality. If it's poor mucosal quality, I would end up recommending doing temporoparietal fascia. I think if it fails, your options then are still great. You haven't burned bridges. And I think it's that's such a successful technique in general. I think it's worth kind of going that route first. If it's really great mucosal quality, I will go ahead and do the open approach. I think that is a robust repair and can be almost foolproof in a lot of these patients. And then very large, I think you're kind of stuck into the alloderm mucoperichondral flap technique. And again, I don't do really the very, very large ones. So post-op regimen arguably is just as important to me as the surgery itself. I think I always tell patients, you had a perfect repair. There was no question if that was the case. So now it is up to you, and it is probably 50% in your hands as to whether this repair is successful. So I harp on a ton of nasal moisture. They do nasal saline sprays, drops, about 4 times a day. I tell them you cannot overdo it at this phase. And then we rotate as long as those elastic splints are in place with either bacitracin or mupirocin, depending on the patient, and Aquaphor every other week until those elastic splints are out. I always have them get a humidifier in their home. They avoid all nasal sprays, antihistamines, steroids, all of those things. And I have a very low threshold for starting a course of oral antibiotics if patients get sick. I think one of the worst things that can happen is for patients to get some horrible sinus infection early on in their post-op time period. So I'm a little bit more aggressive, even if it's something that may still be viral. I still tend to just jump on and put it and send in some antibiotics. A couple of just nuances. In very large perforations, if a patient has a bump on their nose or a tension nose, sometimes you need to do a dorsal reduction to be able to recruit more available mucosa, and that is an excellent tool that you can use to be able to close this technique, to be able to close a really large perforation using the open technique. So that's something to counsel patients about ahead of time. Sometimes also you have to consider you may need more cartilage than the nose has available. I use donor cartilage. You can use rib cartilage if that's something that you're comfortable with. But always have that as a backup plan if you don't have, because a lot of these perforations just have no cartilage left in their nose. And for perforations without a known cause, of course, do a workup. We didn't really talk about the workup phase of this, but I do have a low threshold for biopsy in patients where there's no explanation for the perforation. So definitely do that workup. And if I can say one thing, please avoid the septal button if you at all can. I've seen several cases where that was put in and it just doubled the size of a perforation within months. So I'm not a fan of those if you can at all help it. Obviously, there's extenuating situations to everything, but those are some nuances there. These are my references. Thank you so much. Appreciate it. Any questions? I think the TP fascia is a little bit more robust from a blood supply standpoint. I wouldn't, because you're essentially leaving exposed alloderm. I think that would probably be a last case scenario. I think I'd still go with sort of their own tissue. I think the ability to kind of rescaffold over fascia like that may be a little bit better, especially just exposed like that. I think it would dry out easier too.
I'm not saying I've tried it, I love the Creutzfeldt.
Yeah, I haven't tried that. Be interesting.
What would you say your success rate is with the Creutzfeldt fascia?
It's been 100%. So, yeah. So. In these situations, I think the lower percentage rate described in literature is because people are using them for pretty large perforations as well, and I don't think it's as successful with that, from my understanding.
Do you go through insurance, or is this more cash pay being a cosmetic product?
So I don't take insurance, so it's an interesting niche, and neither did Crydell where I trained. You certainly can, and I started my practice taking insurance, but I have no advice on how to get actually reimbursed for these cases via insurance, because it's tough. So.
Have you worked with the Biozyme graft?
Which one?
The Biozyme?
No, I haven't.
Extracellular matrix,
Yeah.
graft for a whole lot of parallel septal application too.
Yeah, I haven't worked with that. I'd be interested to know more, though.
Are you doing 6 to 8 weeks on your cytlastic splints on the temporal parietal fascia as well?
Yes, absolutely. I think that's just a really nice protection, and I think it's kind of universal with all repairs there. And patients really do tolerate it well. I think, in the beginning they're kind of freaking out, but they really do, they tolerate it well long term. Anybody else? All right, thank you guys.
We are running a little ahead of schedule, which is a wonderful thing. We are going to get started on our next panel, which is a Mohs panel directed by Dr. Jeff Lackey. This is an interesting panel here. We're going to have myself as well as 2 other surgeons who close Mohs defects. Before I get into introducing Dr. Lackey, I'd like to introduce them. So Dr. Pam Hansen is a general otolaryngologist who closes Mohs defects in a very large volume in Montgomery. She was trained by some gentlemen who taught her always to have 5 different closures for each defect before she went in. Very useful person to have on this panel. Myself, I am a head and neck surgical oncologist. I was trained in microvascular free flaps. I also do large pedicle flaps, and I tend to be the otolaryngologist often of last resort for several Mohs surgeons, and I end up doing lots of local flap closures in precarious areas, but also neck dissections, porodectomies, and as you can imagine, all sorts of other kind of sticky situations that a Mohs surgeon could get into. And last is Matt. Geez, I'm saying a lot. Sorry about that, guys. It's Saturday morning. This is rough for the host here. So Matt Migneron, who just came back to Tulane as an assistant professor of head and neck surgical oncology, or actually head and neck, ear, nose, and throat, and head and neck surgery, as well as facial plastics, and he works with Jeff up at Tulane with the facial plastics and things. Jeff is a very remarkable man. He went to medical school in Bethesda and then did his dermatology residency at Walter Reed. After completing his Mohs surgery, he obviously has been performing Mohs and teaching Mohs surgery to dermatology residents now. He served 25 years in the armed services and has had some very interesting and very important jobs out of that. One of them includes being the, Jeff, you've done a lot of things here, man. No, he was the advisor to the Surgeon General for dermatology. This is wonderful. In 2013, he retired from the military. He came to New Orleans, where he's been practicing as an assistant professor since then. So.
All right, clicker here.
Yes, there you go.
Big green button. All right. Thank you for that. I think any Mohs surgeon who's invited to speak at a conference like this kind of enters the room with fear and trepidation. Just because you guys do such amazing work, and I do some work on the outside of the nose and the outside of the ear, and I enter into those spaces very nervously sometimes. So I always love having these guys around. And sometimes we make some big holes that we really need help with. But today I wanted to talk about, well, first, no disclosures. I don't have anything to disclose. I wanted to review kind of just what are the usual malignancies that you can involve a Mohs surgeon for, a brief summary of how the technique works. If you haven't seen it before, it can be helpful. And then hopefully the meat of this is I've got about 11 or 12 cases that I've done over the years. Some of them are reconstructive conundrums. Some of them are just management of just bad cancers, which I appreciate having these guys around for. So the first thing that I found interesting when I got into this is who manages skin cancers. Because obviously dermatologists manage skin cancers, but then all the other people on the screen here manage skin cancers to some degree. And all the way at the bottom of the second column, you see undifferentiated physicians, physician extenders, and the internet. I find those three being some of the most difficult to recover from when patients come to me after they've been treated by folks like that. This is Southern Louisiana, where if you have a medical license, you can practice whatever you're comfortable with. And whatever you're comfortable with is obviously a very subjective thing. So we have some folks here doing Mohs surgery who aren't dermatologists, who aren't board certified in any relevant specialty. So I find that particularly difficult. But the types of skin cancers that I have treated over the years, almost everything on this list I've done at some point. Some of them are less amenable to management with frozen sections, with just typical hematoxylin and eosin staining, so some of them will require some additional kinds of techniques. But the ones that I spend the majority of my time with are basal cell carcinomas, squamous cell carcinomas, and to a lesser extent, malignant melanomas. So as in dermatology, we've got tons of ways to fix skin cancers, from cutting them out to scraping them off to treating them with things to shooting them with things. But the one that obviously I spend most of my time doing is micrographic surgery. This is what my patients think it is when they show up in my office. They think it's mole surgery. My father-in-law, after 30 years of knowing me, still thinks all I do is just kind of slice off moles every day. And so he calls it mole surgery, as do a lot of my patients. A lot of them call it Mohs surgery because they think Mohs is an acronym, and then a lot of them just think it's nose surgery because they're coming in for something on their nose and the procedure sounds like the word nose. But what it really is a method of mapping out tumors, tracking and excising positive margins, preserving as much normal tissue as possible. For me, this is almost always an outpatient procedure. Very occasionally, I don't have OR privileges, nor do most dermatologists, but luckily I have friends who do. So I've done a few cases in the OR, which can be a protracted event because I take my Mohs layer, I run back over to the clinic, I process the tissue, run back, so there's like 45 minutes of waiting time. So some poor resident sits there with the patient under anesthesia while I'm clearing some monster tumor, and then these guys come behind me and take care of wrapping things up at the end. It's a fun way for us to do surgery, but very resource intensive. So obviously this is, like I said, this is not an acronym. It's named after Frederick Mohs, who's the guy who pioneered this, who was not a dermatologist. He sort of came up with this idea of peripheral margin control as a medical student in the 30s. So that's when this was kind of pioneered. It's been done for many years now, but probably only within the last 20 years has it become kind of widely accepted. There's lots of articles discussing the meteoric rise of Mohs surgery and how much we do Mohs surgery. With that has been a lot of abuse of Mohs surgery, doing Mohs surgery on things that don't need it because it reimburses higher. So the specialty is been in sort of a state of flux, but we're kind of narrowing that down to we're much more of a traditional specialty. So folks who can perform Mohs surgery, folks like myself, fellowship-trained dermatologists, is usually my preference if you're going to have a Mohs surgeon. But there is, the window is closing, but there has been a window of opportunity for dermatologists who don't have kind of formal training in this to take the micrographic surgery and dermatologic oncology exam and be board certified as a Mohs surgeon. But most of their training is just the cases they got as a resident and then kind of on-the-job experience. And then, like I said, the other way to do micrographic surgery is just if you feel like it. So there are folks who do it in the community, and it's, again, not my favorite way. What fellowship training look like? It's typically a year-long fellowship. There are still a couple out there that are two-year fellowships and add an MPH onto the end. We're now ACGME accredited with kind of a minimum caseload you got to do, and we learned the Mohs frozen section interpretation, which I would argue is the hardest part of the residency, or the fellowship, excuse me. Most of us, if we come from a good residency program, have good surgical training when we get there, but you spend the year learning to do a lot of the stuff that these guys also do too, to a limited extent. And then we learn about non-surgical management. And like I said, we've had our own board exam for the last 4 years. The window is closing after this year. After that, the only way to become a Mohs surgeon and get board certified is to do a fellowship, an ACGME accredited fellowship. So the way this works is we have a tumor that we've identified that has to be treated. I almost always debulk these. I curette them. If it's a basal cell carcinoma and I'm not worried about tumor histology too much, I curette the crap out of these things. I don't want a positive margin. I want to clear these things as quickly as possible and get the patient out the door and save insurance reimbursement some money. But I also, if it's an aggressive squamous cell carcinoma, I will not curette. I will sharply excise the debulk, either process that myself or send off to pathology to assess for lymphovascular invasion or perineural invasion. We take a small margin around that debulk, and then we keep it oriented, a couple of hash marks around so we can identify the 12 and the 9, so we keep track of where things are. Get that out of there. I usually gross it myself, meaning just if I need to relax the skin to get the epidermal edge to lie down all the way around, I'll do that, get it off to my tech who freezes it, gets it in the cryostat as quickly as possible, and cuts very thin layers, and then gets it on a slide for me. We have just an automated linear stainer, so this is typical H&E. So my technician can, and you can see it on one of the slides later, he can, from the time I drop off a piece of tissue to the time that he's handing me a process slide, can be as quick as about 12 or 13 minutes, which was crazy fast. Usually he's waiting on me, not the other way around. That was Fred Mohs, the guy in the picture there. So the idea here is I keep this oriented. I can mark specifically where I see tumor, and then track it out very precisely. So I'm down to this one little area, go back and take just another little swipe, get it clear. Once it's on the slide, generally I am working with smaller pieces of tissue, and I like to have the whole thing processed kind of en face in one piece, and I can see the entire epidermal edge all the way around in the entire deep margin. And therein kind of lies the benefit of doing this the way we do it, so that you get complete margin assessment all the way around, instead of bread loafing through this like we would with an excision. And then, I don't know if it's showing up there, probably not as well, but I can see little foci of tumor and then a little higher power. This is a basal cell carcinoma kind of growing off of the underside of the epidermis. So when to think about sending a patient for Mohs surgery, often it's just location. If if it's on the nose, it's on the ear, it's the brow, the eyelid, where you want to conserve as much skin as possible, we can be very helpful with that. If it's just a big tumor that you, and I've done this a couple times with my ENT colleagues, big tumor on the scalp, they really just want me to clear the periphery before they go deep. That can be helpful. And then any of these tumors that we've put up here, we're pretty comfortable with. I will say I've got lentigo maligna here. I don't really advocate yet for Mohs surgery or modified Mohs surgery for invasive melanomas, unless it's on some very specified sites. If it's on an eyelid, if it's on the helix of the ear, I probably would get your Mohs surgeon involved. So either they can do it under frozen section with immunohistochemical staining, or do it staged excision with en-face margins. Can be helpful. And I've done that a couple times with Dr. Aslan. And if you've got a patient who's immunosuppressed, these patients, their tumors are sometimes notoriously hard to control, so just getting a good peripheral margin can be helpful. There are NCCN guidelines for all of these tumors for the most part, which I go by pretty strictly. And then we have a set of appropriate use criteria that the Mohs College has put out basically to try to corral what I was talking about earlier, where you've got a 4 millimeter basal cell on the back. That's not appropriate for Mohs, but there were people who would try to do that. So we try to corral that and keep it in the realm of what makes sense. So what we can do for you, routine basal cell carcinoma, squamous cell carcinomas, and most of our Mohs surgeons are glad to clear the tumor and send it back to you for repair. Or if it's something you're overwhelmed and you want us to do the repair, for the most part, I think I'm comfortable. Sounds like there are some other places where Mohs surgeons are increasingly not wanting to do repairs as much. The bigger thing that I enjoy, especially in the university setting, is being a multidisciplinary partner with you guys. For extensively invasive tissue, I think we can, or extensively invasive tumors, we can provide some benefit. Things that are on the central face, like I said, or the ear. And then, like the tumor I was talking about earlier that I cleared with Dr. Friedlander a couple of years ago, very invasive squamous cell carcinoma that we already know has bony involvement. I will clear a moat around it. So I say, hey, Paul, your outside boundary is clear. You just got to go deep. You don't have to worry about the rest, and that can be helpful. The other thing that I do, and particularly at academic centers, often Mohs surgeons will be involved in tumor board. I run a cutaneous oncology tumor board at Tulane, which is kind of cool because Matt's department also runs their head and neck tumor board, and a lot of times there's a lot of interplay. Our patients get kind of reviewed at both tumor boards, so that we really get good care. So that was as brief as I can make it, I think. Any questions about the Mohs surgery process before I go on to the cases? All right. So Matt and I were talking earlier in the week. I think that at least for Mohs surgeons and maybe reconstructive surgeons in general, the temptation is to bring to these talks just your best outcomes, right? Make you look as wonderful as possible. This is Southern Louisiana. I have a lot of patients who I get them to where they are functional and they're happy with their result, but it's not always the best outcome for me because they don't have the financial or insurance resources to come back for me to kind of tweak things. So you'll see some of that this morning. So the first case is more a management, like a head and neck surgery conundrum management issue, but also with reconstructive issues that I had to deal with. So this was a very healthy 80-year-old with a moderately differentiated squamous cell carcinoma, about 1.5 centimeters diameter, which is well within kind of our ballpark. Kind of warning flags to me when I brought him in is this was somewhat, it didn't move around a whole lot. So I was already worried that I might have some kind of deeper structure involvement. And this was a few years ago. Our guidelines have since kind of progressed with time, and I would have gotten probably imaging beforehand. I did not. But this is kind of how we would stage this now. We use kind of two systems, the AJCC, which would have called this a T3. And I'm calling it T3 basically just because I'm concerned about deep invasion. And the same for the Brigham and Women's Hospital staging. It would have been a T2A because it's got one high-risk factor. So that's probably my first question. Knowing that you've got a tumor that is kind of almost bound down to the orbital rim here, plow ahead or do something different? I'll tell you, I plowed ahead.
So I'll just go ahead and start since I'm in a more rural, smaller areas, the general ENT. If it wasn't fixed, I would have plowed ahead, but because of the post-op care, that would be, if there was complications for the hospital aspect and he had to go in, I would actually defer that up to UAB just because it was fixed. Sometimes our instruments in our smaller rural area is not that great. So on this one, just because of what would happen and all the possible afterwards, that one I would refer on. But if it wasn't fixed, I would definitely go ahead and do almost like a rotational flap. But if I did have the resources to do it, go for it and scrape and get your margins down to that bone, to that periosteal layer.
I think if the Mohs surgeon gave me a call and this patient ended up in my office just for a preliminary evaluation for a closure, or even if they didn't come to my office, I probably would advise getting either a CT of facial bone and neck, or just a CT of the facial bone. I might consider an MR of the orbit, depending on exactly where that is. My institution is pretty easy to get an MR of the orbit, and I get nice cuts of the subcutaneous of tissue, but really I'm good with a CT of the face.
Yeah, I don't really think I have anything to add. I would probably get imaging first, and then kind of go from there.
Right.
It's a kind of a cop-out answer.
Right, and actually, as I've kind of gone through this and matured over the last several years, and I've spent a lot of time with these guys, I probably would have imaged him as myself now, because I do that now pretty routinely. I think I'm the only dermatologist who routinely orders imaging. So talked about that. The next question would have been, for me now, knowing what I know with this one, had I gotten imaging, now our guidelines are throwing in their sentinel lymph node biopsies, because it is now increasingly being done at institutions, and we've done it here a couple of times. So, however, I mentioned that I plowed ahead, right? So I did, and I cleared this tumor, but I don't know if it really shows from the photo. I was really right down on the bone, so it grew right through underlying facial muscles, through the fat, and I was scraping the last layer, which was clear. I think it was layer 4 or 5, was clear, and I preserved periosteum. But in doing so, he had extensive perineural invasion. Let's see. So we did get a CT right after this, when I realized what I had latched onto, which was an unremarkable CT. But this was what I ran into in him. So when you see a nerve that is in the fat like this one is, it's pretty much by definition greater than 0.1 millimeters in diameter, and that's kind of our cutoff for what we think it places you at higher risk for metastasis or regional involvement. And he had multiple foci of this. So this is in muscle. So what that does for staging is moves this up now to, it doesn't change AJCC staging, but what it does, and what I highlight, I don't know if you guys are using Brigham and Women's, but it moves him up to a T2B because he had perineural invasion. And from the kind of studies that have been done, if the T2A and T2B delineation in the Brigham and Women's system really kind of helps figure out which ones are most at risk for subsequent problems. So perineural invasion, and then this was extending beyond subcutaneous fat. And then if you pay attention to the NCCN stratification, anything that's poorly differentiated, aggressive subtype, bigger than 4 centimeters, or there's the perineural invasion of 0.1 millimeters. And something that I suspect will probably be added to the guidelines in the record for this is lymphovascular invasion. So. All right, so reconstructive options. What do you want to do, Dr. Mignon?
I would probably rotate in some kind of mini cervical facial flap, following along the lid cheek margin, come up above the lid at the lateral canthus, and rotate.
All right. Other thoughts?
So, yeah, I mean, you should certainly do that. I'm a little bit worried about pulling the lower lid down. A rhomboid may be helpful in this situation, but again, that could also pull the lid down. I really would want to come from lateral for any local flap more than anything else, and try to kind of preserve the lateral vector, or to work with the lateral vector and preserve that position of the lower lid. But a local flap, certainly, and I don't think it needs to be it doesn't have to be enormous.
Right. All right.
I agree. I would actually do almost like a modified V to Y type advancement flap.
She's very, very good, which is what I did, right? So I did a modified V to Y, and I like creating this big triangle up kind of outside of your normal V to Y, so you can kind of transpose that across, preserve the eyelid. And he did really well. So management from here, because of the perineural invasion, I did end up sending him to Cutaneous Oncology Tumor Board, and we sent him for adjuvant radiotherapy. He's had no recurrence at 18 months, and he's doing well. He didn't no pull on the eyelid. He did great. So, all right.
He does have that new lesion on the forehead, though.
Well, that was why he was in my office. So. I have a ton of repeat business. So, all right. So this one was pretty interesting. This was a superficial a squamous cell carcinoma in situ that one of my ENT colleagues had tried to excise and put a graft on, and then realized when he sent his specimen into path, every margin was involved. Which when I ended up clearing this tumor, I think it was 6 or 7 stages. You can see why every margin was involved. So he had lost pretty much, 75% of the front of the auricle and a fair amount of the back. My first inclination, if this patient was much older, this guy's only about 55 or 60, young guy, he's actually got young kids, he's working, he's active, my older patients, we probably would have said, hey, cartilage is really expendable, let's just cut this off and close you up and get back to whatever it is, I'll leave you enough to hang your glasses on. I didn't feel comfortable doing this, nor did he. So this one was a little bit of a conundrum for me about how to fix a degloved ear. What do you guys think?
So I actually had something very similar, but it was an invasive squamous cell carcinoma. And there's actually a new sheepskin stomach product that works really well that I tacked down, and it healed up really well just because of the turnover rate. Unfortunately, he did not listen to the post-op care very well. Granted, he was in his late 80s, and with imaging and everything else, there was actually a little bit of extension into the external auditory canal. So he ended up having a recurrence and then going up to UAB and getting Picasso'd. But that sheepskin, stomach skin worked really well.
I have used the sheepskin stuff a couple times, and it was very nice. Yeah. All right. Other thoughts?
So I think with this patient, I kind of had some realistic, like, cosmetic versus, like, practical conversations. I mean, if he I first tell him, like, look, this ear is not going to look like the other. It's just not going to do that, okay? And you got to understand that. Sometimes, yeah, I will use some sort of dermal matrix on somebody like this. The other option is you can bury that in the postauricular skin, and there's a very good take rate. You release the buried ear, and you can either put a graft behind the ear in an inconspicuous location as the back of the ear is. Or you can let it granulate in, or even put a little dermal matrix back there. But burying the ear is certainly an option, although this is quite a large defect. You may not have the ability to turn it. It's kind of hard to say by the.
Yeah, I did sort of a combination of all those things. The first thing I teach my residents, if a defect's just so big you don't know how to close it, make it smaller first, right? So I just took a wedge out of the bottom first. And you're right, I had the discussion, this ear is going to look roughly like an ear, but not like the other one. And he's like, Doc, I'm cool with that, all right? So first of all, just made this smaller. Then I was able, he had enough skin over the kind of the superior helix to kind of just undermine and pull that over and get it sort of sewed the top of the helix. And then I did sort of a modification of that. I didn't bury the ear, but I raised a little flap from behind the ear and kind of just sewed it right along. My residents call this a book flap, but an interpolated scalp flap. And that's what it looked like when it was done. And I kind of like was biting my fingernails and sent him home, hoping this would work out. Amazingly, he came back at a couple of months, and it was granulating beautifully. And this is at about a year, and he's done great, and he's very happy with it. He brought me a box of cigars. So
I really love this. I mean, you didn't have to cover the whole ear, and you got a really nice kind of that edge of the ear. There's a reasonable cosmetic, but more kind of a practical like thickness of skin there that you got with that. Would you have ever put some sort of dermal graft on the rest of the ear with that, or?
So yes, in a perfect world, that would be great. In an outpatient clinic, I don't often have access to a lot of the cool stuff that Matt might in the OR. So when I first started my career, I would try to do grafts inside the ear, the antihelix, conchal bowl, and I was never really happy with how they looked. And then at one point, somebody told me, "Why are you doing all this? Just let it granulate." So almost anything that's not on the helix, the front or the back of the ear, I just let it granulate, and they really do great. I'll throw some gel foam in there, and I'm very, very careful about how to tell the patient to take care of it. Because I have had a couple that didn't do that, and it showed. So. All right. So do I really have 4 minutes?
No, you have 34.
Oh, okay, good. All right. So this is another gentleman. He's a carpenter. He did not want to take a lot of time off from work. Didn't want to really do anything past one stage and one day of surgery. So we're like, okay, let's do it. It's basal cell carcinoma. It didn't feel particularly fixed. I don't do routinely imaging on basal cell carcinomas. But the warning flag is this has been here for probably 15 years, right? So after about, I want to say this was 5 stages, he's left with this defect, and that white stuff you see at the bottom is periosteum. This was a really fun learning case for my resident because she really got some good experience with bleeding that was squirting at her during the procedure, which my dermatology residents are distinctly uncomfortable with. But I think it's good learning for them. All right, so tumor's clear. This is really just a reconstruction question. Thoughts?
Yeah, I mean, I think obviously breaking it down into a couple of different subunit reconstructions is where I would start. I'd probably advance the cheek as far medially as I could. And then the conversation is, what do you do to the sidewall? I think you could kind of run the gamut. We did one recently that was pretty similar to this, but a much older gentleman. We just advanced the cheek to the kind of the nasofacial junction and then allowed that second part to granulate in. I think this defect is a little bit bigger than that. I think you could kind of run the gamut with what you do on the nose, but I would consider either just a skin graft for that portion of things, or you could try to convince him to let you rotate some kind of flap down. But like we've talked about down here in Louisiana, people are much more interested in getting back to work quickly. So a lot of people will like to go with skin graft.
Right.
I think kind of the adage that you had in the previous case where you try to make the defect smaller and bring kind of the tissue in surrounding before you advance the flap could be very useful in this type of case. I had the benefit of working with Sham Baker for a month, and I was, as a resident, I always remember how much, as a resident, I was just shocked how much he would deglove the face before he closed something like this. I mean, deglove the nose all the way to the contralateral side and all the way out on the face, and really get the laxity out of your local flap that you can get before you close an area like this. I think you could advance something from the nasolabial area once you kind of bring the tissue in a little bit more and deglove and have a pretty good cosmetic result there. You might do it in 2 local flaps. Curious how you close it.
I'm curious as well. So originally I would have been doing a large rotational from the cheek flap, but to get it as small as possible. But being in Alabama, rural area, like Matt said, they want to get back to work ASAP and they don't care. But at the same time, for a full thickness skin graft for him, he is a carpenter, he works outside. we got to also be concerned of what are we going to be adding if we do a full thickness skin graft. If we take it from the neck, from his previous sun exposure, I would counsel the patient, if that has to be done, we might have to go in. You might get another skin cancer just because I'm going to be moving it because we don't know what's showed up from before. And you may have to go back in later or along with the topical 5-fluorouracil.
Right. She brings up a really good point, and I've run into this in the past with some plastics colleagues. For me, when I do a skin graft, site selection is huge because most of my patients are pasty white guys who have been in the sun for far too long. Any sun-exposed surface is almost just off limits for a skin graft, just because I'm afraid I'm just going to be moving one tumor into the spot I've just cleared. Probably my favorite, if I'm going to do a larger skin graft and I really care what it looks like, is right here, because it's sun protected in almost everybody. This was so deep, though, I really didn't want to throw a graft in this because it was just going to look like garbage. And I was obviously, honestly, a little bit concerned about how well it would take at the bottom of this. So I did sort of a combination of a couple of things. One, I brought the nose over as far as I can get it. I love moving the top of the nose into a defect. You put a triangle right in the tip if you've got a big enough nose. Undermine to the other side of the nose, under the muscle, pull it all over and sew it into place. And then I did a big V to Y from right along the melolabial fold. The problem I ran into is it wouldn't go far enough, right? And I have done some huge flaps, rotational flaps. I don't like doing them at 4 o'clock in the afternoon in my outpatient clinic when the entire ENT clinic has already gone home, right? So I usually will try something that's a little bit easier to get me to where I want to be. The other challenge I had, this V to Y advancement flap, there was nothing to sew to medially because it was just periosteum, and I couldn't get it to move quite far enough. And that's when I called Riz, and I'm kind of panicked. And I'm like, I think I have a pretty deep hole here, and I'm worried about bleeding. What should I do? And he's like, put a bandage on it. So I did. I packed it with gel foam, told the guy, hey, we're probably going to have to revise this. When this contracts, it's going to look awful. And this is what he looked like at about 6 months. That center portion granulated really well. He's actually really happy with this. He's a little asymmetric, as you can tell. He's got some lift on that right ala. And I'm not super happy with the way the scar looks along the nasofacial sulcus there. However, it got him back to work. He didn't care about cosmesis. He has not let me do anything with this, not even inject it with Kinalog. He's like, nope, I'm happy. Can I go back to work now? So I was overall pretty happy with this considering the trouble I had with it. So. All right, the next one is a little bit more of a management case, and this is probably one of the most difficult cases that I've had over the years. This is a very sweet lady who is the wife of a 4-star general. So can I use the word sphincter tone here? Sure. Was already pretty tight because of who she is, right? She's also got a squamous cell carcinoma, and I was always immediately wondering, it's so weird that she has 2 squamous cell carcinomas because both were biopsied as squamous cell carcinomas. So weird that she has 2 right next to each other. That's crazy. She's a transplant patient. Her renal graft is 5 or 6 years old and just kind of doing okay. She's a very socially active lady, not very compliant medically. So she takes tacrolimus. When she would come in for her tacrolimus levels, they have been as high as 4 times therapeutic. So she's immunosuppressed. And when I bring her in for Mohs, and I do my lymph node exam, she's got a little pea-sized little nodule right here. Went ahead and cleared those 2 tumors, and I was like, that's so weird. I thought they would connect, but they didn't. But I put it back together. I won't belabor the reconstruction here because I want to get to the meat of this. I just did a little Burroughs advancement, which you could argue I really just pulled the eyelid over more than I advanced anything. But it worked out and got her closed. But then I had to figure out what to do next. I've got a patient who's got immunosuppression. I'm now concerned that I just cleared a primary tumor and an in-transit metastasis. And she's got a nodule that I can feel. So I think I know what you guys would do, but what do you think?
I mean, obviously start with, get some imaging of the rest of the face and the neck. You're gonna be a little bit limited because she's got the renal transplant, so you're not gonna be able to get contrast. So I don't know, probably consider even getting an MRI as well, just to look at everything.
You know, I'm in a suburban metropolis, and I have big hospitals that do a lot of head and neck. I have neuroradiologists that I can work with, and I would, in my practice, at least get a CT without contrast of the neck, and then I would also get an MRI, including to where the lesion is, and talking to the neuroradiologist, making sure that we get those cuts, and they can correlate them together in a meaningful way. Whereas, you know, obviously you can't give her contrast. It's too bad. But we tend to get very good imaging and be able to stage things and kind of preoperatively evaluate people very well that way. And I understand that's not the way that a lot of the country works, or even some very good hospitals work, but that's what I would do.
Being in a smaller area like that, we have a cancer group that works very well with us, and they prefer just to, once you get the diagnosis, just to pass them off so they can do all their imaging in their own house.
Yeah, we kind of did a combination of those things. We got a CT without contrast, and often when I'm ordering imaging, I make a call to these guys first and say, hey, this patient's coming to you. I want to order imaging. What do you want? And this was kind of what the head and neck surgeon preferred, was an XCT. Obviously, we would have liked with contrast, but we couldn't do it. He ended up doing needle aspirate, was consistent with metastatic squamous cell carcinoma. So we sent her to tumor board. She ended up getting a superficial parotidectomy and a neck dissection. And then she also got adjuvant radiotherapy to the right side of the face, including the parotid. We did not radiate the primary tumor because the thought was, you've cleared that, we've got the metastasis, she's got metastatic disease anyway, let's focus on the parotid. Talked about adjuvant immunotherapy, which obviously we couldn't do because that would also tend to kill off her graft. This was after a really well done neck dissection and advancement flap. She did great. But this is at about 6 months. She's got 2 new little spots here that we biopsied that were consistent with the same thing we had just removed 6 months previously, squamous cell carcinoma. Can I go back? Yeah. So and she's been irradiated. So A and B are both squamous cell carcinoma. If you look, there's some little red papules around the cheek there that also probably are the same thing. So now what do we do?
Well, my first question is for pathology, how deep and extensive was that proved that it was squamous cell? Because if it's going to be a little bit more superficial, you can go back and you can do your 5-fluorouracil.
Well, this was a poorly differentiated squamous cell carcinoma, and these were shaved biopsies, so we didn't get real deep, so we're not accessing depth, but it is the same exact poorly differentiated tumor that I had removed from here.
First, I would talk with the radiation and medical oncologist. That would be the first step before I'd go back in and cut or apply anything else.
Right. Their answer was, well, we'll start with medical oncology. So she's just got skin disease. We're not touching her because they don't have anything that they can give her that wouldn't knock out her kidneys and still work well. Radiation oncology is like, we just irradiated that. We're not going back right now. You guys have some surgical options. Go do that. So that was the way tumor board discussion went. So I'm going back with this again to do Mohs. Now she's had, I love having a healthy parotid because it protects me from getting into the facial nerve. Now I've got missing part of the parotid. I'm concerned if I go back to do Mohs in this preauricular area, I'm going to get into the facial nerve. So, hey guys, can you help me with this? This was one of the cases we went to the main OR to do. This was me mapping out tumor before we started. And the minute I start kind of curetting away at these, all of it's friable, poorly differentiated squamous cell carcinoma. After I've curetted, before I've taken my Mohs layer. 2 or 3 Mohs layers later, and like 6 hours later, she's still in the OR under anesthesia. The last Mohs layer, my friend Wayne Cardoni took because I was like, Wayne, because we're right under the ear there, taking the last layer. Wayne, can you do this one? I really don't. If anybody cuts the facial nerve, I'd rather it be you. So, and he did. So I was kind of standing there telling him, cut here, cut here, cut here, and he did it. And finally, of course, they're isolating the nerve and paying attention. So Anything else we would do at that point? Here's the big one, that if you've got patients who are immunosuppressed and they're on tacrolimus and they're popping skin cancers like this, talk to the transplant team about switching them to sirolimus. There is evidence that this can really slow things down, which we did. We switched her to sirolimus, serial imaging with non-contrast CT. 6 months later, B, which we were concerned, that's just a redundant little dog ear at the bottom of the flap. A was recurrent squamous cell carcinoma. But still no evidence of disease other than in the skin.
How are you assessing that? Are you getting an MR or a CT to kind of assess?
We're serial non-contrast CTs. So no evidence of regional extension into parotid or lymph nodes. It's still just cutaneous disease.
You're up again.
Right, you're up again.
Yeah, well, so yeah, and I'm like, really, again, we're doing this? So at this point, I'm basically just playing whack-a-mole, right? Just trying to catch cutaneous things as they show up. But after that one, she's done 9 years, getting her sirolimus down to a level that keeps her kidney alive, and we kind of limits the immunosuppression as much as possible. They're still removing new stuff from her. They just had a little tumor in her eyelid. I keep track of her. She's one of the few patients that I've long since moved away, but I keep track of her. So that one was just a tough one to manage, and I feel like it was like a 3-year Mohs case. So we'll go something that's just reconstruction now. All right. Pretty cosmetically sensitive, very well put together 75-year-old lady. It's got what looks like a small basal cell carcinoma on her nose. 4 stages later, it's a big whack on her nose. Talked to her about a few things that were possible, and she was planning, she's Catholic, she was planning, I forget the name of the pilgrimage you do in Spain where you walk across Spain. She was about to go do that a couple of months later. She wanted this kind of fixed up as quick as possible. Thoughts?
Well, there's a couple of different options. Obviously, the biggest one would be your paramedian forehead flap. But since she wants to be done and go quickly, you can do a bilobe transposition, and that you got to just be very careful of elevating that alar, nasal ala, because you don't want to do that. One of the things that I do like, I'm not sure I'd be able to get enough tissue on it though, but to close a smaller gap would be an island pedicle, and then do another maybe single rotation flap in there.
I don't have anything to add to that. That's a lovely answer. Yeah.
All right.
Probably push for a forehead, but understanding what her limitations are.
Yeah, and I present forehead flaps to patients. 1 time out of 10 they take it. So it's just a hard sell for a lot of my patients. Mainly probably because I'm dealing with mostly folks who are in their 70s or 80s. They're like, that sounds awful. I'm not going to do that. So we came up with something a little bit different. I decided to do the dorsal nasal flap, or the Riger flap. I didn't think I would get it all there and get her completely covered. So I told her, hey, we're probably going to move this as much as we can and then maybe graft what's left, with the idea that I keep the graft on the nasal sidewall off of the nasal dorsum. So that's what we did, pulled that down, took a little graft. I think I took it from the preauricular cheek here. And she really did pretty well. I think this is at suture removal, so the graft is looking like a graft looks at a week. And then probably 6 weeks later, this is kind of what she looked like. I'm actually fairly happy with the symmetry of the nose. I haven't ganked anything up. The graft looks like garbage, though, and I really don't like that. So I talked to her about doing something else to help with the graft, which is this, right? So I'm a dermatologist. I trained on lasers. I can use a CO2 laser. I can use a pulse dye laser. I hate it. I hate lasers. Full disclosure, I hate cosmetics just in general. I'm sorry, Claire, if you're still in the room. I just don't enjoy cosmetics, and so I don't have those things around. But what I do have is a $5 pack of sandpaper from Home Depot, which we cut into strips. I like to get the variety pack, so you have like a 120 grit, a 150 grit, and a 180 grit. And seriously, you take these things, you cut them in strips, you put them in a blister pack, run them through your autoclave, and I just keep a drawer full of them. And when I have these, I don't do any local anesthesia with needles. I give them, I get around a prescription for EMLA. I say, come to my office an hour early. So we're going to put you in a room. I absolutely like icing like on a cupcake to the whole nose, let them sit for an hour, and then they'll let me sand away on them. If this is any carpenters in the room, you start with the roughest grit possible, the lowest grit, and work your way up to feathering out the things at the end. So this is about 3 or 4 weeks after the dermabrasion. I'm much happier with the way the graft looks. She's still a little red, which will get better. If I had the aforementioned PDL, I would have treated her with this. But anyway, she was pretty happy with it, and she went on her trip and did fine. All right. Okay, so I mentioned carpenters who don't go to the doctor. You've seen this one before. I showed you this one before. So carpenter works way down the river, has no health insurance, makes too much money for Medicaid, has no insurance through his employer. He works outside all the time. He's had this for years, and he's like, yeah, I like to keep a scab on it because it's the only thing that makes it look like my nose is all in one piece. And oh yeah, and I don't like needles, and I don't like doctors. But he does have a boss who's willing to pay within reason. So I see him in preoperative, because I don't do a lot of pre-op consults, but I see him and I'm like, dude, we're going to take off the side of your nose here. We're probably going to have to do a forehead flap here. There really is not much else I'm going to be able to do to fix that. Ideally, given how much I think I'm going to take off, this might be better done for me to clear the tumor and hand you off to my ear, nose, and throat, head and neck surgery guys so they can take you to the OR, because I don't know what we're getting into on the inside of the nose. And he's like, no, I'm not doing that. I only want you to do it, and it needs to be one day. And his boss, who I can't think of him as anything else as Fat Tony, because he's like this big dude sitting over in a chair just kind of watching the whole thing and saying, how much is it going to cost me, Doc? So we agreed upon a price that was much lower than this ever would have cost anybody to do, and we ended up doing it. So, but this is his defect. As I expected, it's a lot of the defect. All of the alar cartilage is gone. Claire's still in the room. His septum looks beautiful. All right, so obviously the problem here is that I've got to replace not just the covering of the nose, but the structure of the nose, and then I'm missing a ton of mucosa. So what do you guys do with this?
Send it to UAP.
In one stage, not in the operating room?
Yeah, in
One stage, not in the
one
operating
stage
room,
is
under
my
local
problem
anesthesia.
here.
Oh, wait, he has had 5 milligrams of Valium.
Yeah, probably plenty. I don't even know where I'd start with one stage.
Well, it's not one stage. I ended up
Yeah.
doing a forehead flap. But
Yeah.
So there's, right.
I mean, there's 3 components to reconstruct, right? Your nasal lining, then you've got to give them some kind of cartilaginous support, and then something for skin. So, I mean, I would not do this in the clinic if my life depended on it. I would go to the operating room. Where'd you get your cartilage from?
Okay, so what I did was I took as big a piece of conchal cartilage as I could from, I think, the left ear. And I generally like going behind the ear, just make a big flap, open it up, get out a big chunk that's roughly, arch-shaped. Didn't feel like I had enough to really kind of rebuild the nasal tip, so I just got as big a chunk as I could, sewed it across from the tip to the lateral ala, which it was a beefy chunk. I was not concerned about losing patency. And then I told him, I said, we've got to replace the skin on the inside of the nose. How are you with kind of plucking long nasal hairs for the rest of your life? He was like, I don't care. So I ended up just designing my forehead flap way up into his scalp. I went probably a centimeter or 2 into his hairline, right? So designed the forehead flap to cover the outside, but then also just had an extra tongue of tissue going up into the hairline, pulled that down, folded it around underneath the cartilage, and then just sewed it all into place. And kind of held my breath and went home and worried about it all night. He didn't bleed. He didn't have a whole lot of pain. He's a real tough guy. Once I got him through this, he was totally fine. This was at pedicle division. Forehead's looking all right. He's granulating up there. And I told him, this is thick right now. I don't want to thin this very much right now because I would rather, because we've got two sides of this that we've got to get kind of to settle out. I want to see you back. Maybe in 3 or 4 weeks we might thin this. Refused to ever come back. Ghosted me. Wouldn't answer my phone calls. I did finally text him a few times and said, hey, can you at least send me a picture so I know what you look like? And this was him. This was him during the Snowmageddon of 2025. So when we had 10 inches of snow on the ground, he's still outside doing his carpenter thing. So this is the photo I got. So given what I had to work with and that I got no opportunity to kind of tweak this, I was actually pretty happy with this. And he said, this is the best second nose I've ever had, so I'm happy with it. I don't want to do anything else. So anyway, yeah. I don't do these very often, but when you got to do it, you got to do it. All right.
I think that conchal cartilage is key, though. I think I don't think people go to that right away, and I will take it with the skin in the back or the front sometimes, and it takes quite well.
Yeah, it does well. When I first started, I would try to take these little thin pieces of cartilage from up on towards the helix, and I'd get them in there, and they would just kind of do that. Right, so I stopped playing around with that, and I take full thickness cartilage. I make a window, and it's a beefy piece of cartilage. It'll hold the ala up. All right, next case. I think this might be my last management conundrum case. This is one Riz sent to me.
Oh, and then he went to Chicago.
And then he left.
And then he left, right? He was like, hey, what do you want to do with this? And I'm like, well, what is that? So this was a really awful basal cell carcinoma that this woman has had for clearly a long time. We immediately got some imaging of this, and I'm a dermatologist, but I can see the bad thing on this CT scan. So it's obviously kind of looks like it's encroaching on the external auditory canal. What do you do?
I learned my lesson from last time, so I would ship it out.
I'm sorry?
I learned my lesson from last time, so I would ship it out.
So imaging's really important, and on her, I get a temporal bone on these cases, and I get a neck as well. As far as CT imaging goes, I think it's really important to have a good preoperative assessment of where this is going. Sometimes it goes in the parotid. Sometimes it's all ear canal all day. Sometimes it's in the temporal bone, and it's just really inconvenient. So
Yeah.
I'm pretty aggressive with it.
I only showed you one slice. We did all the imaging. It was really just local tumor.
Yeah.
So she didn't have anything else that was concerning.
She's lucky.
All right, so I am the chair of the Cutaneous Oncology Tumor Board, so my threshold for sending people to tumor board is very, very low. But particularly when it looks like a conch shell attached to the head, I'm going to send that to tumor board, which we did. So what we decided for her was, given the size of it, and she already had some hearing loss in that ear, she was very, 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 very kind of wary of doing anything where we were going to be deep inside her ear doing like a sleeve excision or something like that. So we talked about doing neoadjuvant therapy for this with one of the hedgehog inhibitors. I very rarely talk about medicines in general, and this is very, very, very borderline off-label. So sunitinib and vismodegib are approved for basal cell carcinomas that have been treated already surgically or with radiation and have recurred or are surgically unresectable. So surgically unresectable just depends on how you define it. When we were concerned about affecting vital structures and she's worried about getting into the inner ear stuff, then we kind of made the case that this would qualify for neoadjuvant therapy per the guidelines, which we did. If you don't know about these drugs, every derm resident knows this. This is the hedgehog kind of pathway with patched and smoothened transmembrane proteins. In normal skin, the hedgehog ligand binds to patch when you need stuff, when you need hair to grow, when you need your taste buds to regenerate, any of that kind of stuff. That serves a real purpose. The problem is when you get permanent activation of patch 1, which activates smoothen, which activates GLI, which results in downstream transcription and uncontrolled growth, then we get basal cell carcinoma. So sunitinib and vismodegib both bind to smoothen and just turn it off. So after 6 months of turning it off, this is just with the sunitinib. So the tumor clinically appears to have vanished. It's much less notable. On the CT scan, the one on the right is now her updated CT after 6 months of sunitinib. Tumor's obviously still there, but it's much smaller, and we proceeded with surgery at that point. I still ended up going 4 or 5 stages and taking off her entire ear. But we went a little bit into the EAC. I am scraping stuff off of temporal bone, but I did get clear margins. So there's no real great reconstruction that we wanted to do here, particularly given that we had just treated a huge tumor with a hedgehog inhibitor, which creates concerns in my mind as a Mohs surgeon. If you treat tumor, does it all shrink concentrically? Or is there the potential that you get shrinkage and shrinkage and shrinkage and then clearance between foci of tumor? That's always my concern. And I was like, can we not do anything like crazy reconstructive here because we're going to have to be following this lady? So Riz closed it down a little bit and put a graft on it. She continued to sunitinib for the rest of the year and did great. It's not a super well-tolerated drug, but she did all right. Serial imaging inflammation has calmed down. We've had no issues with her. We're just kind of following her over time. So,
Did she actually get a hearing test before any of this?
that's a great question for Dr. Aslan. I have no idea.
Okay. Just because when you lose part of the ear like that, you're normally going to get a couple decibel dB loss anyway, but if she had hearing loss for any other reason, then it would depend on the flap that you can use. But, I mean, that looks great, but I was just curious about her decibel hearing loss beforehand.
I don't know. I mean, it's an excellent question, just not one I ever even considered because I'm a dermatologist. But she was very, very happy because she could get her hearing aid back in now, where she could not before with the thing growing off of her ear. So, right. So interesting case. This is a tumor. Was a recurrent presentation at tumor board over the case of several months while we figured her out. Okay, the next one, tiny little basal cell carcinoma. I hate these because they're right on the alar rim. They look like that's awfully close to the soft triangle, but it's small. We'll probably get away with doing something easy. And she's good friends with my department chair and very cosmetically sensitive. So, yeah, it ended up being all the way through the ala and bigger than we anticipated. She does have a beautiful forehead, in case you're curious. But she's clear and obviously missing some structure.
So I've had a lot of luck with taking, again, that conchal cartilage. I'll take it with the skin, I'll take it without the skin, but I always take that full fat piece of cartilage because it does, correct me if I'm wrong, that whole crura is gone there, right?
That's why I've got gauze stuck up in there so you can see.
She's gonna have just total collapse if you I've seen some guys just put a flap right on that. I'm puzzled why they think that's gonna work. So I take a nice fat piece of the cartilage from the ear. I don't think she's gonna cosmetically mine that. It looks pretty good after we do it. And then I'd probably scoot some sort of local flap in the area, depending on what we could figure out. In this case, to rebuild the mucosa, I would leave the skin on there. It does have a pretty good take rate.
Yeah, she's not missing much mucosa. It's a little bit. But. Anybody else?
Yeah, I think that's what I would do. She's not going to want a forehead.
She did
And
not. Because we had that discussion. I was like,
too big enough of a defect for one, really. Why?
All right. So what I did, she's got a pretty healthy cheek, meaning I just look at the distance between the ala and the tear trough and figure out how much I've got to work with here. I really like a little kind of paranasal interpolation flap. I once again reached for my conchal bowl cartilage graft stuck that in there, kind of shaped it up so it was roughly even with the other side, and then just flipped that little interpolation flap over and sewed it into place. So careful with these. If you thin the distal flap too much, they will turn a lovely shade of ebony and fall off. So, but she did great. I think I dermabraided her at probably a couple of months out, and she did really well. She was very happy. She got good symmetry. The scar was not super noticeable. I am still, after doing this a number of times, still tweaking, getting that alar groove to look right when I inset my flap here. So that's an area that I'm still tweaking.
So I tend to get a lot of scarring in that crease, and it looks weird because it's heaping on the one side and nice and pinched in on the other. What do you tend to do to kind of sculpt that in a more meaningful way and to get that to match the contralateral side?
You talking about in the groove itself?
Yeah.
I have raised this and kind of debrided it a little bit, removed a little bit of tissue, thinned it out a little bit, sewn it back down. I have just injected intralesional Kenalog, which the biggest thing right now, she's got that little bit of prominence right there. If you put a little Kenalog 5 in there a couple of times, a lot of times it will just kind of settle out and not be super noticeable. But I have had to pull it up and reshape it. It's a tough spot to get to look beautiful. All right. Similar, this was a malignant melanoma in situ, which I do not do with frozen sections. I do this staged excision with rapid on-phos permanent sections. Fortunately, she cleared in one stage, and the mucosa is intact. We're not technically inside the ala, but we're right on the soft triangle. She's very, very cosmetically sensitive.
You can do a bilobed. That would work in this case.
And I should say, she's really got no collapse of the ala at all.
Okay.
For whatever reason, she still looks pretty good.
So in matter on that, you're just rotating the skin, and you can do the bilobed. You can also consider in this one a V to Y. I don't think you can get enough skin for an island pedicle, even though that's one of my favorites. But you could, even if any of the tissue doesn't work, it all depends when I get in there of how movable that tissue is. And how much other skin damage there is. You can also even consider a preauricular full thickness skin graft if you're not getting the rotation and the cosmesis that you're looking for.
It's got a lot of eye makeup on there. I'm not sure I'd take the graft. I think she cares about that color, but I completely agree. I think a bilobe would be a big go-to for me. The V to Y would be really nice. Again, this is a case where I would just really widely deglove. And see what you're left with, how much you can kind of pull it into it without warping or misshaping the nose.
I agree. I think the only thing I would really keep in mind is, we're essentially at the alar margin, so you have to really be careful about any kind of contracture there. I think a bilobe would be good.
I trained with Don Grandy in Boston, who's an excellent surgeon, but the year I was with him, he was really down on bilobes. We didn't do a lot of bilobes, but we did a ton of V to Ys. And I still reach for it, and I've modified it over the years so that now a lot of times my V to Y is more a nasalis sling flap than just a straight V to Y. So bilevel undermining above and below the nasalis as far as you can go. And then these things honestly will swing a long way and get good coverage. And she ended up doing really well. This is probably a couple of months out. I'm pretty good with the structure and the shape, not at all good with my scar lines. So I reached for my handy dandy 3M sandpaper, and she ended up doing much, much better, and she was really happy with this. So, all right, I got a couple more cases. I'm gonna try to get through them here real quick. All right, so basal cell carcinoma, which looks small, and this is why Mohs surgery can be very helpful. If you excise this and throw a flap into it, only to realize that this was the actual basal cell carcinoma, and this was the defect that I was left with. He's probably 50. This has been about 10 years ago. He's about 50 years old. He's got pretty good laxity below. Obviously, he's got a pretty tight forehead.
Think of some kind of laterally based local flap feeling from that temporal area. But the problem with that is we're going to distort his temporal hairline a fair amount. But I still probably would.
Yeah, I might consider a rhomboid for this. It may be useful depending on how you design it, without taking down the hairline or pulling in the hairline and not necessarily pulling out the supraorbital skin too much.
All right. That's really honestly what I decided was going to make the most sense. When I teach my residents how to design rhomboid flaps, I say, look, take 3 equally shaped triangles, put them together like this, and then kind of remove the lines, and you've got a rhombic. And it helps them kind of visualize how to do this. But this kept me out of his hairline and did not really impact I had already removed a good portion of his eyebrow, but I did not lift his brow with this. So that was kind of how that ended up looking. You can see me drawing all over him. We considered a big rotation flap, all kinds of other stuff. Sometimes it looks like a 4-year-old's been drawing on my patients by the time I finally get to doing the thing that I want to do. But from the front, I'm pretty pleased with this. This was at suture removal, or his first follow-up. And then this was a few months later. He did well. He was happy with it. So, the rhomboid is one I don't use very often, but sometimes it's like the only thing that really makes sense. All right, I think I have 2 minutes. We'll try to get through. I think this is the last one. This was a malignant melanoma in situ, or Lentigo maligna. Took me a couple of stages over a couple of weeks to clear it, but I'm left with this defect. And I think my repair is going to be probably pretty much what you guys would do. There's some things I did wrong that I'll highlight, though.
Yeah. Yeah, I would probably consider some kind of rotational cheek flap or even a rhomboid in this situation, just laterally basing your tension, not to pull anything on that lower lid. That's going to be the main concern here, is giving him an ectropion.
Right.
And even pulling that nasal layer through that nasal fold.
I mean, you could do a V to Y. You just have to be really careful with that, what vector you're pulling in.
Yeah, I was really already into the lower eyelid, and I was really, really worried about what I was going to do. I didn't want to give him an ectropion, obviously. So this is one of those cases that, again, you could argue, that is it wise to do these in the clinic? And my residents' eyes usually get really big when they realize what I'm about to do. But he did great. I did basically a big Mastardi took it above the zygoma, around in front of the ear. I'm trying to remember, I think I took a little triangle out behind the ear just to get everything to move up. I did not do what we always say we should do, is go ahead and complete the cosmetic subunit and take it all the way to the nasofacial sulcus there. You could argue that I should have done that. Again, I pushed this to the limit that I'm comfortable with, and I'm more comfortable than some Mohs surgeons about what I'll do in the clinic. But to get it another centimeter or 2 over, I feel like I would have been way down in the neck, and I'm not super comfortable with that. But he did very, very well. This is a couple of weeks later, and then about a year later, he did great. So I was glad at that point I didn't try to push, trying to get it all the way over to the nose. But he did great. So, all right, I think we're out of time. Questions for me? I'll hang around in the back if you guys have questions for how best to abuse or use a Mohs surgeon.
So we're going to take a 30-minute break here, and then we'll be back in here at 9:30 for our head and neck section. Thank you.